Meeting to order at 9 a.m. on Thursday, February 26th for the District Board of Health. And it's going to be a great meeting. I can just feel it in the air. And it's warm and it's not snowing. So we're going to celebrate that as well. I'd like to go ahead and call roll call, please.
Vice Chair Andriola.
Present.
Paul Anderson.
Here.
Run.
Here.
Dr. Duarte.
Here.
Steve Driscoll.
Here.
Dr. Danko is not present and Devin Reese is present. We do have a quorum.
Thank you so much. I'd like to ask Dr. Duarte if he would do the Pledge of Allegiance, please.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. We'll now move to public comment.
Comments heard under this item will be limited to 3 minutes per person and may pertain to matters both on and off the board agenda. Time may not be allocated to other speakers. Comments are to be made to the board as a whole, and virtual public comment to be taken when facilities are available. Speakers' viewpoint will not be restricted. However, reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant statements, unduly repetitious statements, and personal attacks that would objectively antagonize or incite others are examples of speech that may be reasonably limited. This was the business of Northern Nevada Public Health and its citizens during its meetings. The presiding officer may order a person removed if the person's conduct, statements disrupt the order or safety of the meeting. Warnings about disruptive conduct or comments may or may not be given prior to the meeting. Furthermore, certain disruptions of a public meeting or criminal acts as defined under NRS, which may result in prosecution in appropriate cases. We received one e-comment, which was forwarded to the board members and is listed to the record. And we do have one request for public comment. I'd like to call up Jamar May. You're welcome to use the podium.
Good morning, Chair and members of the board. I'd like to start by thanking you for the opportunity to speak today. My name is Jamar May. I'm a culinary entrepreneurship at Truckee Meadows Community and a business management student at the University of Nevada, Reno. I'm also the founder of Mars Mobile Munchies. The original Mars Mobile Munchies sidewalk stand model was developed as a practical learning step, a way to gain real-world learning experience before investing the significant capital required for a full trailer build-up. As a student studying both business management and culinary entrepreneurship, my goal has always been to build responsibly, gain experience, and scale appropriately. I'm here today to respectfully request clarification regarding the implementation of Senate Bill 92 and how the term stand is being interpreted under the sidewalk vendor framework. Senate Bill 92 establishes sidewalk food vending as lawful regulated business activity in Nevada. The statute defines a sidewalk vendor as someone selling food upon a public sidewalk from a convenience, including without limitation, a push cart, stand, display, pedal-driven cart, wagon, showcase, or rack. The word stand is explicitly included. My original concept was intentionally designed as a controlled, limited risk sidewalk stand aligned with NNPH, food safety and equipment standards, not a push cart and not a full mobile food trailer. The design was conceptual and proposed a simple structured setup consisting of 2 tables under a tent, a portable steam table that had been dedicated solely to maintaining proper holding temperatures for pre-cooked meats and canned nacho cheese, with a portable griddle positioned outside of the tent and used strictly for hot finishing. All primary food preparation would have occurred at a permitted commissary kitchen. The setup also included a generator to safely power the steam table and lighting, an NSF certified portable hand washing station, sanitation requirement, and a fire extinguisher to ensure compliance with safety standards. During discussions regarding permitting pathways, the options presented were transitioning to a pushcart model, or moving forward under a full mobile food trailer framework. A stand-based pathway was not presented as viable. Pushcart setup was not feasible for my business model, so I ultimately moved forward under the full trailer route. I recognize how fortunate I am to be able to take that route, but many aspiring small business owners cannot afford the capital required for a full trailer build out. The purpose of Senate Bill 92 was to reduce unnecessary regulatory barriers while still maintaining appropriate food safety standards. So my question is simple. If Senate Bill 92 explicitly includes stands within the statutory definition of sidewalk vendor, what is the regulatory basis for excluding a limited commissary-supported stand model from consideration? I respectfully request clarification on how NNPH interprets stand under Senate Bill 92 and how local implementation aligns with the intent of the law. Thank you for your time and your service to our community.
Thank you, and I hope that staff has your information as they can follow.
I have sent out my email to a few people, but thank you.
Thank you.
Chair, Danko joined at 9:02.
Oh, great. She can hear it's okay.
I can hear you. Can you hear me?
Yes. Hello. Any other public comment?
No.
Thank you. We'll move now to the approval of the agenda. No one has any changes? I'd entertain a motion at this time.
Motion.
We have a motion by Mr. Driscoll. We have a second. Second by Councilmember Anderson. Any further discussion? And all those in favor signify by saying aye.
Aye.
Unanimously. Thank you. Sorry, couldn't resist saying that. We'll move now to the approval of January 22nd, 2026 minutes. If anybody has any changes. Hearing none, I'd like to entertain a motion at this time.
Motion to approve.
We have a motion by Mr. Brown, second by Mr. Driscoll. Discussion. Hearing none, all those in favor signify by saying aye.
Aye.
Any opposed? Motion carries unanimously. We'll move now to item 6. And so today I think everyone has their schedule and their creative thinking caps on and just ready to make this the best retreat yet that you've ever experienced. Certainly the focus of health and looking at community needs, looking at staff needs, looking at financial and the strategies to accomplish navigating the best possible solutions we can offer are always welcome. But just as a reminder, we are working at a 30,000 foot level, and so just want to, and I'm sure that Ms. Olson will help us remind us of that as we sometimes travel in the weeds. But I certainly appreciate that. But in order to make this a memorable experience, I am going to ask that we have a little icebreaker and everyone's going to participate. Everyone. Even the two of you. Oh, yes. Everyone has to participate. Oh, yes. So here's what it is. I'm going to have you think about what have you ever received as either personal or professional advice that you have found to be impactful, either in your personal or professional career. So we'll do the Jeopardy We'll give a minute or two because there's no preparation for this. And I apologize that I'm springing this on, but I hope that you can share with us what that message or messages were given to you. And it can be at any time in your life. So, just looking for who looks like they have it already figured out. We'll just go around the room. So Erica, I'm going to start with you.
Knew you were going to start with me.
Did you feel that?
I did.
You did. Do you want me to shake it up and we'll go on the other side?
Oh, that's okay. I'll jump in. What strikes me, I'm very present in this work right now. So Katie Singelon, many of us know her, of course, is a very impactful mentor of mine. And so she always said to me, in any process that you want to run effectively and impactfully, it always starts with who has the D, who has the decision-making authority and role. And whenever we miss that, we sort of don't clarify that, the processes go off the rails and the change doesn't happen. So that stuck with me.
Brianna, you want me to go back and forth?
Let's go back and forth.
Becca bounced right your way.
I was gonna say, this was advice given to me by my father. He said, anytime there is a problem and you bring it to someone, always have a few solutions as well.
That's awesome. Thank you. Brianna.
Okay, back to me. Kevin once told me, we were talking about, but before he would, I'd always ask him for feedback. And this one particular time, it was a big situation and he said, can I give you feedback? And I just noticed in that moment, it was a pretty big situation. And I try and do that with my staff, but can I give you feedback? So just asking for permission. Sometimes people aren't ready for it just yet. And so that really stuck with me.
Thanks for sharing. We're bouncing.
So mine came from my mother, who was a public school teacher for many, many years. And she used to give graduation commencement addresses, but in one of those addresses, she talked about taking care of your own corner of the world before you can take care of others. So that was really meaningful to me, like making sure I'm taking care of myself and taking care of my corner of the world before I can go out and do the work of taking care of others in the community.
That's awesome.
I think that the themes that always come back to me are it's actually my stepfather, who was an administrator for a number of years with the school district, talked about those universal truths that have been around for millennia, like truth and justice and beneficence and dignity, and like those things that are held true through every generation. And I think that I always try to hold to those things, that I try to hold those values dear to me and never betray those things. So.
Good lesson. Francisco.
When you asked the question, I thought of several things, but one that I've heard pretty consistently through my life, whether it be sports or my career, is focus your energy on what you have control over. And that's your attitude and your effort.
Very true.
My dad has been a really good mentor to me ever since I was a little kid. And he has always given me really good advice in school, which actually applies to me when I started working. I actually have two. So one is, he always said, it's not how long you work, it's how efficient you work. I think he said that to get me to go to bed. Yeah, but that actually does work in a work environment. If you can find a way to work more efficiently, do that. The second thing he also always said to me was, if you sweat more when you're preparing, then you'll bleed less when you go to war.
Wow. That's profound.
Hi. So I also was thinking of a few, but I think the one that hits home the most right now for me is that attitude is the difference between an adventure and being overwhelmed, right? So approaching how you approach, if you can approach something with optimism and as a challenge, it becomes an adventure. The situation doesn't change, but your approach to it does.
That's awesome. Thanks. Kinsley.
What comes to mind and what I guided in a lot of points. So earlier in my career, I had a mentor, I was trying to decide, well, should I really apply for this position? And he said, make them tell you no. So it's a good way to approach something, if you never ask, the answer is always no, right? So make them tell you no, which bleeds into be curious. In every situation, ask the questions. That's listening and being curious at that point. You also have to ask those questions to, maybe it's a no, but you should always still ask those questions to understand what's the whole process, what's everything goes into. Make them tell you no.
Awesome. So we're going to go back over here. I see you. You can't duck. I see you ducking.
When I graduated high school, what I shared with the class in my speech was a quote that I had heard was, the most interesting people I know didn't know at 22 what they wanted to do with their lives. And some of the most interesting 40-year-olds I know still don't. Yeah. And so not knowing what you don't want, what you want to do with your life is okay. And you can always switch even when you're in your 40s, in your 50s, it doesn't matter. Because you're, and whatever you do, don't congratulate yourself too much or berate yourself either. Your choices are half chance and so are everybody else's.
Oh, that's awesome. How old were you when you thought of all that?
I was 18.
Oh, good.
Graduating high school. It was a quote that I heard and I shared.
Oh, thanks for sharing.
I really can't think of anything off the top of my head.
If you make it up, we'll never know.
I'm just thinking just always, you know, put your best foot forward and be a good example and try to do your best all the time.
Thank you.
Well, you know, my career's mainly been in public safety, and years ago, I asked a fire chief, that was an outgoing fire chief, you know, he was very successful in my eyes, in our community's eyes. And I said, what did it? How did you do this? And he says, you know, never forget to surround yourself with people that are smart.
Always.
And allow them to perform to the expectations. So it's worked.
Happy to have you here, so we have a smart person.
Oh, sure.
Ironically, it's almost the exact same.
Oh.
No, seriously, it was my father-in-law when I was a young manager. He said, don't be afraid to hire and promote people that you know are smarter than you and more talented than you, because it's easy to be a good leader when you are surrounded by good employees.
You're here. Mr. Huarte.
As a young physician, I had a colleague who always seemed to have more success in getting people well than I did, even though I seemed to know more science. He reminded me over lunch one day that it's relationships that heal.
Oh, how beautiful. Dania.
Arrange whatever pieces come your way. Take what you get and make it work. Sometimes you have to move the horizon to do that.
That's beautiful. Dr. Danko.
Thank you. What beautiful insight from everybody. It's really nice to hear that. I think for me, all the good ones are taken. No, I'm just kidding. What I thought through right from the beginning is be kind. Kindness heals, and you really never know what people are going through. And I think that's true for me in my personal life, but also very true for me in my professional life. I've spent about 20 years working in hospitals where a lot of bad things happen in hospitals, and miracles come out of hospitals too. But behind those miracles and those success stories are really tough struggles and journeys. And a lot of the time people share stories with me that the regular outside world doesn't know. Sometimes the workplace doesn't know. Sometimes even the friends don't know. It's hard to be vulnerable in those places. So just know you don't know what people struggle with, and kindness can heal. A smile can heal. Somebody who might be angry or irate, which happens in all of our jobs all the time, might be just somebody who's struggling that much harder.
Thank you. Thanks for sharing.
I became a manager at a pretty young age, and so that realized that a lot of things I didn't know. And so I spent time researching and taking classes, and a theme that came through, especially being in the public forward businesses that I was in my entire life, was to actively listen. And then to take a breath before you have your next comment, to make sure that you're actually letting it set in and have it go forward, so that you're reacting properly instead of just thinking about what you're going to say.
That's anyone? Anybody in the audience want to share? With that. All right.
Got one step.
Oh, great.
Good morning, everybody. Sorry I'm not in person today, not feeling as well, but I think two things stick out in my mind. The first was when I had my first child. A legendary TS employee, Paul Burr, said he had like 4 daughters, I believe. And he said, even though they thought he was probably the dumbest person on earth, he always just said, just love them. Just love them. So I think from a parenting advice, I think that's a big one. The other one my dad taught me was just about honesty. When I was 16 years old, I was selling a truck and the rear end was almost going out. And he was content on telling the buyer, like, hey, just so you know, it's got a rear end that's going out pretty soon. And I was so mad. I was like, Dad, why would you tell him we're not going to get as much money? And ended up selling it for less than what we asked for. But the rear end went out probably like 2 weeks after we sold it. And that kind of just opened my eyes that if you're honest and upfront with people, you're going to avoid a lot of different problems down the road. Thank you.
Thank you. That's good advice. Anybody else that I'm missing? Second chance? Okay. Well, I have a couple too, and a lot actually were shared. So what an inspirational way to start off a day. But for me, I was at the legislature and I was a lot younger than I am now. And a young lady by the name of Carol Villardo asked me if I wanted to go have a smoke. I don't smoke. But we all know that she smoked. It was about 1 a.m. in the morning, and we went under the lamppost in front of the legislature. She put her hands on my shoulder and she said, I was dealing with some, because at the legislature is always a lot of happiness and a lot of, so the particular legislation that I was moving through, had some interesting twists and turns. And she put her hand on, well, first I knew it was interesting because she asked me if I wanted to smoke, and she doesn't smoke. So she, again, put her hands on my shoulders and she looked at me and she said, do you realize that what you have done has not ever been done here? And at least as long as however long she has been there. And I'm just going to give you some advice. And the advice is continue to always do your research, always know the facts, look at all the sides, but always have the courage to do the right thing for the right reasons. And you can put your head down on the pillow and know that you're helping, in this case, all the folks that you're trying to help. So for me, I really held that to a very dear place in my heart, because sometimes when you're having to make decisions, not ever knowing that I'd be in the position I'm in, you have to have the courage to do what's right always and know that it's the right thing, even if it's not necessarily. So living that is not always easy. And then I'll just end it with one thing that I've always shared, especially in public speaking, which I guess is like right up there with the most nerve-wracking thing to ever do, right? Is to public speak. And I always remember where people, really famous people like Pavarotti was asked one time, do you ever get nervous speaking or singing or going? And he said, of course I do. But the difference is that I always have butterflies, and the difference is I try and make the butterflies fly in formation. And I never forgot that. So today I hope we can make the butterflies in terms of what we're trying to do, fly in formation, and have this really powerful opportunity to make a difference in our community, share all of the hard work that you guys do. And we're really blessed to have each and every one of you recognize not only that's here, but is part of the entire team. So thank you for the opportunity. Thanks to everybody for sharing. Last time, third, no, all right. Well, I'll move now to turning this over. It's going to be facilitated by Erica Olson. Thank you so much with On Strategy for helping to guide us through today. And thank you.
Mr. Underhill, I appreciate it. Before we jump in, Mr. Kingsley, any opening remarks from your chair? And then I'll do the agenda or the discussion stage setting.
No, at this time, just mirroring those same points. Thank you, but also thank you for the staff and the time that you put into this, the preparation. I've thoroughly gone over this, and thank you, Eric, also as well as being that advisor to us and helping through this process. This is always one of our Super Bowls in a sense of the amount of work that goes into this, and as we prepare for this, like Chair Anderilla said, we want to do our research. We want to come here and we want to be able to move our best feet forward. change our horizons where we need to change them, and any impact for our community. So again, thank you for all the staff, for the time put into this, and for the board and your support that we have and feel. So thank you very much.
Awesome. Okay. Let's jump in. We're starting with works way. Okay, awesome. So our conversation and discussion flow is outlined above. It's also in the slides you have in front of you or the handouts you have in front of you. Just a couple of quick ground rules. Taking the advice that I just shared today, we're actually looking for direction and sentiment from the board based on a bunch of different input, if you will, which is, again, a set of information from the community, from staff, from our financial situation, and triangulating that a bit to get the sentiment about where we want to go with the organization over the next 3 years. This sets off the conversation that will refresh our strat plan. So we'll talk a little bit process-wise about that in just a minute. But that's the kind of the point in time of where we are. What's fighting against us is we could be here all day easily. We can be here all week easily. There's a lot to talk about. There always is. So just know that good looks like, great looks like, the general sentiment from the board about what might be on our, as I like to call it, strategic agenda for the next 3 years. What are those areas of focus that we might want to kind of essentially like pull out of the whirlwind, the font size, however you want to think about it in the analogy, so that when we refresh the strat plan, we're able to align the resources as well as the intention of the organization potentially around some of those areas that we're going to hear about today. You know, and I think in the work that we've all done together for many years and in this capacity and other capacities, we never really walk out of these meetings with a dramatic sea change. That's just not how, it's just not how it gets done. It's just not appropriate, actually. So it is the essence and the nuance of where we might want to shift a little bit, or again, where what we might want to pull out of the whirlwind to put energy around and resources around over the next 3 years. So just know that's what I'm looking for. It's going to feel undone on purpose. We are not voting on or taking action on the specific priorities in the strat plan today. We will take the conversation from today and come back to the board after staff work around what the refresh strat plan looks like. So, and I am saying refresh, we are not looking to start from scratch. That's not where this organization is right now. That's not what we heard from the board. That's also not what we heard from staff. So, so just again, just kind of know that. The other thing that I think is really powerful about what we have today that we don't always have in these processes is very good a direction and feedback from the needs of our community. That is the chaw and the chip. And the deck, of course, was, or the packet was sent out in advance because there's a lot of information. We have asked for the team to present, again, a little bit more around the so what. We do not need to read all the slides together. You know, as professionals, we know that it's also really hard to not do. So please know that our intention is to ask our discussion leaders to get to the so what. So with that in mind, we're looking for a bit of 50-50 presentation conversation. With that, I will also set the stage on how much time that we have for said area of discussion and or that topic as the case may be. And if it's the board's pleasure, we'll stay there longer. Just know we're eating into time somewhere else. So the way we're styled is as follows. We're just gonna do a quick high point on the strategic direction and just how this process works. We are going to then jam into the chaw and the chip, which is really the essence of what is the community, what are the community needs. Very, very data-based, very solid process. It's again, great data. We'll talk then about health equity. So again, some information on that. Workforce planning, which is really around staffing needs. And then we will talk about the financial health of the organization, sustainability. We do need to take action on the budget that is being proposed, so please know that. And then also we are looking for guidance on what we are calling the financial guiding principles. We will get there. We'll get there towards the end of the conversation, but I also don't want to shortchange that. So time-wise, I'm trying to get us there. So, and then the board discussion is going to happen throughout, but of course, I will hopefully be pulling together what some of the strategic areas of focus are looking like from our conversation, and we'll see that at the end. So, so I'm kind of keeping a crib sheet on the side. I also don't have flip charts. I will be putting it up as a slide so folks online can see, but also so we all can see in this room as well. So, yeah. Here we go. So with that in mind, Mr. Kingsley is going to walk us through. I'll start us, and then you'll carry on. Just a couple slides on the direction, like how do we actually do the priority setting. Here's our mission. The mission developed a handful of years ago. We are not necessarily, as a team, recommending changing that. It does guide the edges of what NPH is up to. Can I ask someone to read it for us, just to ground us? Anybody feeling like speaking it into? Great, thank you.
To improve and protect our community's quality of life and increase equitable opportunities for better health.
The words are really intentional. There's a lot of intent built into the mission statement. Again, refreshed it maybe 4 years ago. Okay, that feels less old. Good. So anything to say about it, Ray, just as our leader of this process?
We took a lot of time to refine our mission about 4 years ago. With our mission, we also came up with a set of values. You'll notice within NP, we don't necessarily have a vision statement, but we truly want to live by a set of values. And we use our mission to kind of guide the direction that we're headed.
So when we talk about great strat plans, there needs to be directionality somewhere. The directionality in the NNPH strat plan lives in the strategic priorities. This is the framework of our plan. Everything cascades from this. Everything aligns to it. I love butterflies flying in formation. This is what we're intending to align towards. The intention here would be, this is what we're starting with. Our conversation today is going to start to show what might emerge maybe differently. There's many levels of the plan, of course. We may keep exactly these and change some things below it. We'll see just how it emerges. But we have 6 strategic priorities. Again, also very intentional: healthy lives, healthy environment, local culture of health, impactful partnerships, organizational capacity, and financial stability. Underneath all of those are aligned outcomes, KPIs, and actions down to the divisional and team level. So there's a lot of depth around the way in which this plan guides the organization. So a lot of hard work over many years to kind of get all of the infrastructure in place. Does it work perfectly? Plans don't work perfectly. There are intentions, not straitjackets. But these do need to reflect what's important to the organization. So this is our starting point. I just wanted to anchor us there. Then Mr. Kingsley, maybe someone speak to the process by which we build our plan.
So taking from the current strategic priorities, which are wonderful, they have a lot of depth to them, but they're also easy to get behind. That's something that I think many of us, that we can go home sometimes where our heads on the pillows and say that we impact within our community. I think sometimes this is a way of working in public health. We want to continue that, carry that forward. So our strategic plan inputs, so looking for our next 3 years, not only continuing what our current strategic priorities are, but how do we continue to develop and assemble those pieces, as we need to, as put forward for us. So as we develop the next 3-year strategic plan, we grounded in multiple inputs to ensure it's both data-driven and operationally realistic. So we began with the community health assessment data to anchor our priorities and the needs of the community. We incorporate board input to reflect governance direction and policy priorities. We've also invested in doing a foundational services analysis to assess system capacity and service alignment. We also evaluate priority considerations to ensure focus and feasibility. Finally, through leadership workshops, we apply professional judgment, align programs and resources with what is most relevant and sustainable. So together, these inputs ensure the strategic plan is evidence-based and positioned for impact over the next 3 years.
Before we go on to the next one, would it be okay just for just a minute to talk, because this is a good process slide? Ray, could you just mention, like, so this conversation kicks off the next 3 year, the kind of the update for the next 3 years. Give us a little sense on it.
Absolutely. So how this has traditionally worked is we provide information here at the retreat so that the board can give us their perspective on what they would also like us to focus on in the next 3 years or in the next year. And so once we are aligned on the board's priorities, my team goes back and we work with our divisions to actually put all of those ideas into play. And so we're working together to put an action plan together. And we'll talk about the performance reports that I provide quarterly, because we're going to get to a slide that talks about that. But everybody gets to see quarterly what our progress is. And we like to keep the board updated on what your priorities are through those quarterly progress reports. So we'll do a retreat. I'll go back to our divisions. We'll do workshops, if you will. We'll make sure that all of our outcomes are uplifting those priorities that everybody has agreed upon. And then we'll execute those through our performance management system. And I'll come back to the quarterly to provide those to you.
And for this specifically, we would expect the strat plan to come back to the board for approval sometime
in August. Yep, in August.
And any clarifications coming out of today will come back in a regularly scheduled board meeting, just again, in time and all of that. Awesome.
So foundational public health services. So several years ago, again, we wanted to create the foundation of what public health is and the standard that we live in within the nation and resembling other public health initiatives throughout our community, through our state, and our nation. So foundational public health services are basic programs and capabilities every local health department needs in order to keep communities safe and healthy. That includes things like tracking health data, responding to outbreaks and emergencies, ensuring safe food and water, preventing chronic disease, supporting maternal and child health, and having the right staff, systems, and communication in place to do the work effectively. They matter to our strategic plan because they help us focus on what we are expected to do as a public health agency. By aligning our plan to these core services, we make sure we're investing in the essentials, using our resources wisely, and building a department that is strong and sustainable. And so this is always a goalpost that helps us, that we align with, and always help us go back when we need to find that horizon again where we are, look at our values, look at our mission, also our services that we deliver. They are core and allows us to be able to understand what our mission is based on these public health services. Great. So just an overview on board reports, what we supply on a monthly basis to the board. We have our monthly divisional reports that we provide. I will also have some meetings set up with the board so we can also go more into depth if there's another process or if there's more information or data. If we've gone through, we like to provide those monthly data, not only a narrative, but also data for you, so comparable, or being able to know any trends. But we're always looking at our monthly division reports where we're at, but also if there's any improvement there or any process to that, we gladly take direction on that. It's something we want to feel that, are you informed? Are you getting the correct information? That is it digestible? And is it actionable? We have our quarterly reports. Our purpose is really to be able to compare our performance management targets that we've set together and moving forward. And then also we have the new district snapshot. So as we are moving forward, we have our snapshots, but also the capacity of informatics and how we put forward information we're looking to streamline that. We said it's had some great success. So there's always opportunities to improve this and provide the information you need to make, have the research and the data there to make those decisions that impact our community. So overall, any questions on this for board reports or anything that the board would like to see?
I have a quick question. I know you're saying board reports, but does some of this information get shared with the public? I know that the amount of media channels that you use are vast and consistent. And I will be honest, I don't look at every single thing. I wish I could, but I just can't. So I'm just wondering, especially on the district snapshot and the quarterly results, does that type of information get shared publicly?
So in different forms. So one, they're all public record, you know, but did they get lost? So I also take the monthly divisional reports, and that is, so every 6 months when I go to each of the districts, or when I go to each of the jurisdictions, it's based off these reports. So it's kind of a secondary kind of summary of, hey, here's the past 6 months. And previously I've also brought the district snapshot, and sometimes that's simpler when coming. So it's another aspect of doing that. But I do believe, as we've seen success, like with our respiratory dashboard, for example, we have wonderful like, how can we make this digestible and tractable that somebody from the community can just sign on and instantly see that information, and it's actualized per month, those things. So I think there's some development there. So another way, how do we make it more easily accessible to the community? So yes, correct answer, it's available to community, but can we do better on making it digestible and easier to access? I think that's a great point. So. Any directors, any other insights on that? Why we have this here? Is there anything, so we do, have encouraged our staff as well in their meetings that when these monthly division reports are out, that they review them, but also understand what's going on in other divisions. We will find the media does go through them, especially when it's important, but sometimes they breeze over it on those points. And I think when our directors come up and present to the board, they're really taking that one snapshot that we feel that's most relevant to you in that moment at that point. So.
Just as a follow-up, I think some of the partners that are connected in deeper ways that align with the particular information, and I was wondering if we shared with them.
Reaching out, we don't ever want to bombard them, but that is a good way. I think also with each of our staff has those wonderful connections out there, and so they can make it more meaningful and go in a way to receive feedback. Our cooperative systemic process.
Hey, Chad, could I say something real quick?
Yeah, Scott.
Scott Oxelrod, Communications Manager for NNPH for the record. We also, Chair, will have our data publications and reports page on our website. You can access it off the homepage. It has all of our reports that we have, including the CHIP, the CHA, the strategic plan, our health equity plan report. All of our major reports that are all public facing can be found there, as well as some archive stuff. We do plan on kind of optimizing that page a little bit to make it a little bit more graphic heavy instead of just links. And I think once we get this in a better position past this meeting, I think you'll see some more visual elements that are available to the public. Thank you.
Thanks. You are always on it. Honestly, thanks for all you do, by the way.
Yes, I think one of the things that's very important, and having lived in the public realm for a long time, staff reports are very important. I think the staff here, I think they write their staff reports well. They write it in a language that's understandable by anybody who reasonably is interested. And that's really difficult to do because we live in the world of words, medical words and technical words and rules and regs and acronyms. And so I compliment the work that we do because someone can sit down and they can get through it without having to go to a dictionary or having to call and ask for further clarification. And we're really pretty good about starting at A and ending at Z. And if there's any clarification needed, I have found that as a particular member, if I ask a question, that the person that's written the staff report very quickly has an answer. So it's not stuff in the cloud being crazy. It's actually a document that can be used and archived. So thank you very much, staff.
Thanks. Okay. I believe on the next slide, we actually went into that question.
Did you?
So
That's good.
and overall, just to reiterate, is the, oh no, if you put the question out, is the board getting information needed to govern it? So I just, any other thoughts on that? That we can do, see any more effective. Okay, thank you very much.
Cool. We'll move on then. Let's jump into the first of 4, essentially like data stage setting, 3 years, if you will, which all culminate in the notion of like what the needs might be from the various different areas that we're talking about. So Kelly is going to walk us through.
Where would you like me to stand? Okay.
You're comfortable with that? That would.
Okay, that's fine. Yeah.
Fantastic. So Kelly's going to walk us through the chip and the chaw. There's quite a bit of information here, as we're all well aware. We've got about 30 to 40 minutes in total for Kelly's high-level points, as well as the conversation. So just like, and we're expecting it to be interactive, of course, too. So
That's great.
the floor is yours.
Great, thank you. So thank you very much for having me be here today. I am an epidemiologist and statistician by training, so I absolutely love talking about data. I love collecting data, and I like using data to empower decision-making, evidence-based decision-making. So before we get started, I always give this cautionary tale that when we are talking about data, we're really talking about it from a population health lens. And so what this means is individuals contribute to these data points, but these data points likewise are the lens that we use to actually understand the impact on individuals. So it is dynamic, it's ever changing, and I'll go into how we collect this data and then really what those results are and where we would like to go from here, looking at the results that we have. Essentially, we do have a very robust steering committee. This steering committee is full of representatives that play active roles and leadership roles or engagement roles within our population, educational roles, and they are key players and provide that agency of our communities to really direct the entire process as we go through and design data collection, look at the data, make sure that we are representing all of the populations we want to represent, and likewise informing the Washoe County community of the effective different health and well-being components that impact them. So our agenda is pretty simplified for today. We are going to go through what our actual community health rankings are. We'll give you a very brief snapshot of what they look like so you can orient yourself. Then we'll go into what data actually feeds into this prioritization technique. We'll explain what that technique is, how that methodology influences how we come out with these rankings, essential rankings of our health and well-being issues. And then we'll give you a very brief snapshot of the top 4 priorities that we have. However, I do want to refer you to I believe it's a handout that was emailed and might be in front of you. It is a summary sheet. For lack of a better word, it is a tentative executive summary that does provide a more in-depth look at all ranking topics, what feeds into them, and some of the basic outputs and results that we have for all those topics. For the sake of time, we're going to focus on the top 4 that were an output of this entire process. So what are these rankings? As you can see here, we have 8 high-level topics in general, but every single topic has these subtopics.
And you'll notice that many of these are not mutually exclusive, meaning although we have these topics that fit under this higher heading, many of these are interconnected. And we recognize that even though we are talking about prioritization, it really is ultimately a circle where no one stands alone and no individual health, whether it's medical or non-medical drivers of health, actually exist in a silo. So we always give that disclaimer as we talk that we do know that these are complex topics that we're trying to look at in really a not necessarily simplistic way, but in a way that we can understand it and then make sure that we develop these measurable impacts and plans to make sure that we are able to focus on these gaps in services and systematic issues. So, what does our pyramid look like? So this is simply a visual representation of our rankings. And so at the top, the highest priority that came out of our ranking methodology is mental health. That is followed by second, access to health services, economic stability, and so on and so forth. So we're going to give you a little bit of detail in each of these. But the thing about data is that it's essentially, as much as we work on active data collection and in capturing community voice, we know that as soon as you capture that data and analyze it, it's already in the past. It's essentially this timestamp of data that shows what is happening in a snapshot of a community. And we'll talk about how we considered that and community voice into the actual ranking methodology. So what actually goes into this very complex, there's almost 500,000 people in Washoe County. How do we actually represent everyone equitably? How do we collect data from massive secondary data sets? How do we focus on a very short time frame to capture the input of our community members and figure out how we synthesize all of this into a meaningful document and guidance for planning? So we have what we typically call primary data and secondary data. Primary data is simply data that we collected directly from Washoe County community members. This is a joint endeavor with Renown Health. They've been absolutely wonderful partners with us and also bringing in a new service perspective to us about how we can all work together to improve our community. So primary data includes things that I'll go into greater detail on, but that's focus groups, key informant interviews, and a community survey. So this is in a way a mixture of what we call qualitative data and quantitative data. Now, secondary data is data that's already been systematically gathered. So these data either exist through different agencies and different points in the county, different state and federal offices, and essentially other existing data sources. We will go into how complex both of these data sets can be and how we essentially go about categorizing in a way that can actually be absorbed and something that can be accessible not just to you, but anyone that's interested in the CHA when it is ultimately published. So, primary data. So primary data has essentially focus groups and key informant interviews, and then a community health survey. So focus groups and key informant interviews are essentially narratives that we perform a thematic analysis on. So what this means is focus groups, we had 15 in total, about 75 minutes each, and 5 to 10 participants each. And they're really conversations that we guide and want to have the community members actively participate and talk to each other and talk to us and really give this narrative of what it means to have the different qualities and components of a healthy community. What actually qualities exist, what components exist, and what are the barriers to having a healthy community. And so there were about 110 participants in total. And from these narratives, we really extract these themes. And I'll show you what those themes are from this analysis as we go into our different rankings. And this is a way for us to not just understand, we can take quantitative data, we can take these secondary data sources that exist for different purposes. And what we really want to get though is the perceptions of the community. And so what they are actually experiencing, how they actually feel about different health issues. That can be in alignment with different data sources, or it might be something new and emerging. Their worries for the future, how they're feeling right now, how the different environments that they exist in, whether that's a workforce environment, whether that's their neighborhood, how all of that comes together for their various perceptions and what they see as potentially emerging conditions within the community. For CAMFORM interviews, again, it's essentially semi-structured interviews. It's 19 subject matter experts. So essentially, we give this semi-guided interview where they provide and give their feedback on what they see as these high-level systematic issues that affect the individuals in our community. So they help us really extract priority populations, system level barriers, system level gaps, but also potentially system level strengths and how those strengths are playing into this complex circle that we have of all these influences affecting how our community lives. Now, the Community Health Survey had about 694 participants. And we're really looking at the magnitude of these community health topics. So this is pretty easy for many people to understand. We ask as much as possible non-biased questions where we simply try to fill in gaps identified by the steering committee, things that they have thought we don't have enough data on, where maybe we need to focus and ask very pointed questions. We often use something called a Likert scale to ask, whether they strongly agree or strongly disagree, and we have different phases within that agreement that we can look and see how people actually view various components and various quantitative data. So we do point blank at one point ask them, can you please rank your top priorities? So give us your first, second, and third. And then we also worked with our steering committee to fill in some of those blanks. So that could be anything from, for instance, our steering committee said, we really don't have any good pointed perceptions on reproductive health. So we asked some reproductive health questions. There was also a lot of interest in active living and safety and how safety can affect active living. That could be anything from bike lanes and what motivates people to go out and exercise and what might be a barrier to them going out and exercising. So all of these analyses, all of these themes will be published ultimately in a very comprehensive CHA, but what we're going to give today is a snapshot of how all of this went into the rankings and hopefully help you all understand those priorities and really use that for that evidence-based decision making. So out of primary data, we also have secondary data. So secondary data is pretty complex. Essentially, we have almost 350 secondary data indicators that come from over 50 data sources. So we work with the Conduent Healthy Communities Institute, and they essentially take a wide range of data sources. Now, these data sources are vetted data sources. They have valid methodologies for their surveys, for their data collection. They understand the data source. They regularly publish, whether that's yearly or monthly, so we know that these are reliable indicators. They publish those methodologies as well, so we know if the data can be compared to previous years, how there might be changes. And we also look at that geographic level. So we are the county, we are Washoe County. So essentially, the secondary data are a score, a numeric score that is assigned to each indicator, and it considers Washoe County and a particular indicator such as the incidence of lung cancer amongst a specific age group. And it looks at what that incidence of lung cancer is in persons age 18 and over in Washoe County. And then it looks at comparative numbers for the state, for other US counties nationwide, Healthy People 2023 targets, and the trend over time. Is the trend going up? Is it going down? What are we actually looking at? It combines all of this into this numeric score where typically a higher score is equal to poorer outcomes, essentially. So I will show you what that looks like. As I stated, there are almost 350 in total, so there is a snapshot today, but there are some reference documents that are available, and ultimately almost 350 will be available, and they are categorized themselves into higher level topics. Okay, so this is just a list of everyone that contributes. Some are local, some are national, some are state. So it really is a very robust centralized database that is always growing and is maintained on a regular basis. Okay, so now we're going to go into the ranking methodology. So this is called the Hanlon method. So essentially, it is a structured way of assigning numeric scores to make objective decision-making in public health. It is a prioritization technique. And so it essentially works where the steering committee and these experts came together and they look at the list of health problems. They really look at what we've done in previous CHAWS. What are these health problems? How do we categorize them? How do we understand them? Then we do the active data collection, which again is that primary and secondary data. Then we assign this numeric score, often called a weight, and then that weight ultimately combines into this high level ranking that will go in today. And so again, this is a summary of what this data analysis looks like, how we synthesize these pieces of data. So primary data has these three components right here. You have secondary data, which is about the 350 indicators that feeds into what are the significant health needs. And then those significant health needs are prioritized for community action. So when we talk about weighing, this is something that we took a lot of consideration into what the community voice looks like. That's the primary data collection. So primary data collection doesn't necessarily have these 350 indicators, but this is where we came together. We did this survey that was in English and Spanish and promoted both by renowned health media teams and NPH media teams. We made sure that we had these locks that we were, that we were adamantly getting Washoe County community members to contribute. We have these focus groups. So we have these key informant interviews. That really is a community voice. And that's something the steering committee brought up. They said, we really cannot necessarily rely just on this retrospective historical data that's in secondary data indicators. We really want to know where there are gaps in these emerging issues. And that's what primary data can help us fulfill. We are actually actively talking to the community members that live here and these key witnesses essentially to what is happening in the health and well-being of our community. Then we essentially go through and assign a weight. This is very similar to how you might remember from school. They'll talk about curves and academic curves and essentially how do you look at what you are collecting. And then you essentially make sure that you have these adjustments to capture the weight of the outcomes that you are looking at. And so you will notice that secondary data in total has a weight of 3, but these 3 primary data sources have a weight of 5. They're essentially weighted a little bit more due to the amount of time, effort, and knowing that these are our Washoe County community members contributing to these rankings. And so again, just as a snapshot, we simply are constrained by time. All of these are important. All of these feed into each other and they all influence each other from top to bottom, bottom to top. I encourage you to think of it more as a circle, but understanding that we do have this systematic ranking technique, and that is what came out as the final rankings, from number 1 being mental health to essentially number 8. And we're just going to focus on the top 4 for time today, but you do have more information on all of them available to you. So number 1 is mental health. So the top table is simply a way for you to see the summary of each individual score, because we do score within the primary and secondary data. And then all of this comes down to that essential, think of it as that grading on a curve, but essentially putting this all together and comparing them across each other to see what comes out as the highest rank. So that's mental health. So what does this mean? Well, as I stated in the community survey, we have a lot of data. All of those analyses will eventually be available, but we asked the community members, 694 of them participated, what is your top priority? 18% said mental health is their number 1 priority. 18% said it's their second priority, and 14% said it would be their third priority. And so this is just a snapshot of how else this primary data collection contributes to this particular community survey rank. We ask things like, how often do you need help? How often do you get the help you need from others when you're feeling sad, worried, or need someone to talk to? And we essentially look at that quantifiable data. We can actually assign how many said never, how many said almost never, and how many said sometimes. And unfortunately, 33% said it was sometimes that they that they get the help they need, which doesn't mean they always get the help that they need. Then we have focus groups. So focus groups identified these high-level key themes: the lack of mental health services and providers, and social and community connection being key critical components of maintaining mental health and what influences mental health. So these select themes include things like mental health options. There are general mental health concerns, feeling alone and disconnected, youth mental health. That came up quite a bit. I'll show you some quotes in a few seconds. And then also the stigma around mental health and how that can actually be a barrier, and how we might overcome these stigmas to make mental health accessible and actually empower people to seek these services. So of the interviews, very similar. Something that was a high-level theme that came up is mental health concerns across the lifespan. And we saw many of the same themes come out in that analysis. Not just how many options we have, the stigmas that still exist around it, these mental health overall concerns, youth mental health, and substance use. And so just to give you some select quotes, because again, themes are essentially taking an analysis from these high-level narratives, but we do want to represent this voice. Basically, a key informant interview quote was, "We're seeing more youth in crisis than ever, but the problems haven't grown to meet the need. Adults are cracking under the weight of cost, caregiving, and crisis. By the time they show up, they're already overwhelmed. And our mental health system is reactive. People have to get really sick before they get help." And please consider these quotes as we continue down, particularly for second, third, and fourth rankings, because you will see how different components that come up here: weight of cost, caregiving, crisis, the fact that it's reactive, not proactive, how that influences health behavior and preventive services. So all of these do feed into each other, and we have mental health at the top, and really it is influenced and also a contributor to a lot of the other topics that we will continue to see. So what does the secondary data look like? So the secondary data, this is a snapshot where you can see that it is categorized under mental health and mental disorders. I don't think I have a laser on here. So hopefully it's available for you to see, but we just want to bring a snapshot that, again, red typically means worse outcomes. So number one here is a score of 2.18. The highest score you can have is 3. And you can see its intentional injury, suicide mortality rate. It gives the units, so that's death per 100,000 population. And in this particular metric, we do have comparative numbers. So unfortunately, you can see here, just as an example, Washoe County has a rate of 24.3 deaths per 100,000 population. The target for healthy people is half that. So we are double what the actual target is in reducing the intentional injury by suicide. We are also higher than the state of Nevada, and we are also higher than the United States. So you can see also, unfortunately, the trend is still going up. And so this is a way for us to synthesize data into a single numeric score. And as you can see, there are sometimes missing components depending on the actual metric. That is not necessarily a bad thing. It's essentially coming down to, is there an exact measure that would make it comparable? If it does not exist, it might exist in a different form, but if it's not directly comparable and measuring the same thing, we don't necessarily want to compare and represent that other Nevada figure unless it exists in that comparable measure. It needs to be pretty close to measuring the exact same thing for it to count on the same line of our secondary data indicators. So I won't spend as much time explaining this as we go forward. I just want you to be aware that there are many components. It can be difficult to tease out, but there's a lot that is in here. And also, again, some of these can overlap in other areas. You see adolescence on here, you see age, you see various components that, again, do represent some of these other areas that we'll be talking about. So access to health services. So again, this table, just a snapshot for you to see how it ranked individually in all these other various primary and secondary data components. This was pretty consistent. It was number 1 for the community survey rank. And essentially we asked them to rank within their number 1 problem that they saw, or number 1 priority, excuse me, that they saw in our community affecting their health. They said 34% said is the first priority, is access to health services. 16% said it's their second priority, 11% said it is their third priority. So we ask various questions to tease that out. What makes it hard for you to get healthcare? Unfortunately, we have quite a few. These are not mutually exclusive, so they can take more than one. People felt that insurance doesn't pay for what they need. They can't get appointments. And if they have insurance, the copay is too much. We don't have enough doctors. We don't have enough specialties. There's not enough doctors taking new patients. All of these feed into what access to health services mean to them. This is only one question. There are more questions. This is just a representation of how people felt when we teased out the various priorities that they gave us. Focus groups said the same thing. It's the lack of healthcare providers. It's the challenges accessing health information. It comes down to health literacy. Is information actually able to be consumed effectively? Are they able to understand chronic disease management? How do we improve our ability to be more inclusive of individuals and their understanding of their health? The select themes, again, medical provider shortage, the high cost, communicable disease prevention, everything from caregiver shortage, medical misdiagnosis, lack of medical supplies. And so again, some of these themes and examples we'll talk about later, but you can see that all of this really comes down to, can you access a doctor and what goes into you accessing a doctor when you need that help? That can be preventive and that can be essentially chronic diseases or chronic management of health. And so key informant interviews, same thing. You have provider shortages, system gaps. How do you navigate the system? It's very complex. You're navigating insurance. You're trying to understand the different providers and specialties available to you. And also the lack of health information and outreach. How do we effectively help individuals navigate these systems and also navigate their own healthcare and empower them for their own healthcare? So these themes come into medical, dental, and vision provider shortage. Caregiver support and the shortages around caregiver support. This is a big deal for individuals that are undergoing cancer treatment. I know that especially at like Texas Children's Hospital, it is often and well known and published that a parent that has a child that has cancer has to go into rigorous treatment. They often have to have one parent that is not working in order for them to get access to the treatments that they need, because it is so time consuming, requires so much attention. It's lack of health information, technology limitations, language access, and health misinformation and health disinformation. Where are people getting their health information? Who do they trust, and how do we build that trust? So some key quotes. We don't have enough professionals who understand the cultures they're serving. We don't have enough providers in almost every specialty. Even for basic care, wait times are months, and those times can be critical to improving the health of individuals that are suffering from chronic or acute conditions. Dental and vision care are almost impossible to get quickly, especially for people on Medicaid. So secondary data, this comes into oral health, STI, healthcare access and quality, who has a routine checkup, who actually has health insurance, who can't see a doctor, maybe a breakdown of why they're unable to afford or see a doctor, children with health insurance. How do you actually make the time and actually make sure that even if health services are available, that they are accessible and they're accessible to the people that need it? And so this also comes down to number 3, which is economic stability. So again, you can see some of these rankings here. What is interesting, I just want to point out, that is something that I think is, we keep a close eye on it in terms of data. And this is something that I think is always important to recognize. Secondary data is often a little bit more out of line with what primary data is telling us, which to me is interesting because we went through why we value primary data. This is what our community is saying they feel. This is what our community is saying they are living right now. Secondary data is a wealth of components and really getting into those nitty-gritty details, but we do prioritize what is happening right now when we're collecting these data for our community. And so 13% said it is their first priority, 9% second, third, 13. And then we ask again, it is a multi-select. These are not mutually exclusive. So people can have multiple issues affecting their ability to pay for services in the last 12 months. And unfortunately, shelter, housing instability is number one. Medical, which feeds into number two, is number two. That's followed by credit card payments and also things like fun things to do, utility bills, and car, transportation, education, student loans. So again, we have these high level categories, but we know that everything comes together in a circle. Focus group said cost of living and community food sources. And those select themes come down to cost of living, lack of housing instability often leads to unsafe neighborhoods, lack of time, lack of program funding, lack of supportive housing, these supportive safety net services, these warm wraparound services, lack of educational opportunities, financial illiteracy, and job availability. So key informant interviews, housing instability, high cost of living. That comes down to insurance costs, prescription costs, the medical insurance dissatisfaction or inaccessibility, and how that also is linked to rental assistance, distance, that can come down to transportation as well, and the lack of housing and supportive housing. Housing is the biggest stressor. If your housing isn't stable, nothing else is. It's not that people don't care about health, they just have to choose between rent and medication. Supportive housing is a huge gap. People fall through the cracks because there's nowhere stable for them to recover. Economic stability. So this is a snapshot of a measure of economy through secondary data indicators, but we also do have many other indicators that are also under here, such as education, community, so on and so forth. Again, it's a very robust document, and this is going to be published. All these indicators will be available when we publish the CHOP. So last but not least, my apologies, that should say health risk behaviors and early detection. So again, quite interesting. The community said that it is extremely high as a priority for them. So they said it is 14% said it was their first or second priority, actually 14% across the board. So it is very consistent in people saying this is important to them. So we asked, how often did you or someone in your household get food from the food bank, pantry, free distribution site? Because it comes down to nutrition, healthy eating, active living. So we had about 11% say a few times. We do have a percentage that also go once a month or once or twice a year or once a week. And so we do ask these questions about how services are being utilized if they are available in the community. Focus groups, concerns of managing chronic illness. So those themes are unhealthy food choices, technology misuse, fall concerns, injury prevention, genetics, infectious disease monitoring, chronic illness. Essentially, one of the quotes that we had was there are insufficient programs to prevent the health issues before they start. And that is very complex and all-encompassing, meaning healthcare system navigation and health management. If people are trying to prevent and stay healthy, do they have access to screenings? Do they have a primary care doctor? Can they go into their primary care doctor? Do they have an appropriate referral process? There's dissatisfaction in that referral process, lack of preventive programs, lack of women's health, lack of sexual health, technology. This is a big one that keeps coming up. And I think that that is telling to us about how technology is playing into health, not just in how people live, but also how people utilize it for healthcare and health language barriers. So transportation, you can't get to appointments, you're not staying healthy. People don't know where to start. Services exist, but unless you're in the system, you don't know what's available. A lot of families don't understand their diagnosis and medications because information isn't in their language or explained clearly. We had an interesting situation that really shows the robustness of health risk behaviors and detection. We had a case that essentially had a GI illness and they are in a sensitive occupation. This is called STEC. It's just a strain of E. coli. But they essentially have to have 2 negative tests consecutively, at least 24 hours apart, before they can be cleared to return to work. So number 1, this is a case, meaning we missed a prevention opportunity. Number 2, they are excluded from work because of the risk of transmitting the infection. So not only do we miss the prevention, but we had to exclude an individual, and this individual, there's typically no treatment for STEC, you clear it on your own, was testing positive for weeks. That is very unusual. And that became an alarming concern as our investigators were talking and trying to help this individual. That means they don't have necessarily an income. They might not have access to insurance. They might not qualify for temporary disability insurance. How are they going to pay their bills? How are they going to access food? And so in this particular case, when looking at it from a whole health perspective, we worked and essentially had our infectious disease consultant look into cutting edge literature to see if there is an ability for us to work with him to have a novel treatment that could be available to this person to help them clear this infection and basically get back up to work. So I like that example because it happened not only recently, but it really talks into these behaviors and how we assess risk, not just to ourselves, but to others, but essentially how important prevention is. But if we don't have prevention, then really what that impact is if people are getting sick or have other issues affecting their morbidity and or unfortunately leading to mortality. We talk about that in statistics and epidemiology. What are the actual years of life lost and what are the years of quality of life that are lost because of different conditions that affect us from all these different environmental factors. So secondary data, this one is extremely robust. We talk about things like immunizations. We talk about nutrition, healthy eating. As I said earlier, fall prevention, injury. That could be anything from safety on bicycles to walking paths to how we program our stoplights and make transportation safer, active living, different physical activity accessibility, cancer, heart disease. All of these can come down to chronic management coupled with prevention and these risk behaviors that influence and also help us stop these from progressing further. And so these are our other 4. I know I'm going fast, but I do want to be mindful of time. We do have, of course, a lot more information. It is not that these aren't important or part of the cycle themselves, but we are just simply working on those priorities because those are what priorities our methodology produce. So this is a snapshot. Again, I do encourage you to just consider how all these pieces of data come together in the ranking. The asterisk does mean that there was a tie, a numeric tie, even as we combined all these various components. So again, it's both a complex process, but also trying to get these results that we can absorb and use. And to leave on a positive note, after throwing a lot of bad news at all of you, so we don't live in utopia. We do know that there are always ways for us to really focus on that altruism and working together and improving our partnerships and doing the good work that we do with our critical partners. Again, strong shout out to Renown Health. They've been a great partner in us for streamlining these activities and having really one strong, cohesive, comprehensive CHA. And these are what people liked. This is a snapshot. This is not all encompassing. People said our healthcare system does have many good elements. People are dedicated. They want to keep helping improve access for families. We have strong partnerships. We want to work together, and we've managed to maintain this strong sense of community, even though our community is dynamic, it's growing, and we know that that comes with challenges. People want to step up into these challenges, and they liked various themes that were identified through these interviews and through the survey. They love our outdoor access, community gardens, the natural environment, the climate and weather. Think about how that affects active living. Plentiful food options, community gardens again, mutual aid groups, food banking services, that nutritional wellness. Are people eating enough? Are they getting nutritious food? And also this social interconnectedness that people keep bringing up as being important to their mental health. What are the good components of that? The good work environment, good social interactions, cultural diversity, and recreational opportunities. So it is a mark of how well all of you, how well many people in our community have come together to really improve these wraparound services and build social connectedness and come together to solve solve these problems together. And people do recognize that and they do put that into our CHA. And again, that is not the only ones that we have. So there will be more when we finally published. And so as always, this cannot exist without the individuals that make up our population in Washoe County. It really is a special thanks to their participation, their continued participation, and those are always who we serve first. We are here for them, to help them. We live and represent this community as well, and we do want people to absolutely live their best life. And so that's essentially it for today.
Wow, thanks for all that. I'm glad we don't have a quiz, but if you were giving us a quiz right now, I certainly appreciate it. But I do know, and I know that there's a second part to this, but I do know that we have a public comment for this item.
Great.
Do you want to have the public comment now after the child result, or do you want to wait?
Yes.
Yes, I thought it might be appropriate, so.
Carrie Kelly from Renown.
Okay, great. Thank you.
Hi, good morning. Thank you all so much for having me. My name is Carrie Kelly and I represent Renown Health, Northern Nevada's leading not-for-profit healthcare network and Nevada's first integrated academic health system and the region's only level 2 trauma center. And I wanted to talk a little bit about this amazing collaboration that has happened with this current CHA. We are doing it joint 50-50 as far as the report. Renown has also done a community health assessment over the last 15 years. So we're able to do this process together. So we're committed to bringing the best possible care to our community. And our vision is clear: to inspire better health for everyone we serve. The community health assessment is one of the most important ways that we advance that vision in partnership with Northern Nevada Public Health. This assessment has been a deeply collaborative process between our two parties and our partners in our community. We know that when community organizations work in alignment towards shared goals, we achieve stronger coordination, reduce duplication, and ultimately improve health outcomes for the populations we serve. This shared approach ensures alignment between public health strategy, healthcare delivery, and community investment. It enables us to prioritize prevention, reduce disparities, and make meaningful progress on the issues that matter most to Washoe County. Sustainable community level change happens through collaboration, shared accountability, and long-term commitment. Renown Health is proud to stand alongside Northern Nevada Public Health in using community health assessment data, not simply as a report, but as a coordinated call to action to build a healthier community for all. Thank you all for being part of the process.
Thank you so much. I'm just going to ask, just procedurally, do you want to hold off any comments or questions? That was a lot of information.
There's a lot of information.
And also share that I'm glad we're not having.
I completely agree with that.
But I don't know what your pleasure is.
Yeah, it's a good question. So I was also processing that as well. So Riona has a couple of summative slides that will help anchor this conversation. Okay, then I think potentially we should take a break. We might need to adjust. And then we need to hear from the board.
No,
it's resonating. So give me a minute to just, we'll have Ray kind of put a bow on this. We'll take a 10-minute break and then we'll come back and have conversation about what or so okay.
Thank you. All right, so what do we do with all of this data? We turn it into the community health plan. Annually, you typically see me up at the podium in county chambers talking about our CHIP is what we refer to it as, because it's our point to basically be accountable to the board on how are we making progress on all this data that we shared with you and what the community's needs are. So Kelly went into the process, how do we collect different data points so that we're looking at every to understand what health actually looks like here in Washoe County. We turn this into a CHIP because this translates all of the data into an actionable and a measure that we can work with our partners to move the needle into improving health outcomes. And we do this through coordinated conversation around what our priorities are. So in a minute, I'm going to share with you what those rankings are. Before we get to that point, we start to transition from the CHA to the CHIP by having a community forum. We had our community forum a couple weeks ago, and we invite all of our community partners to start reacting and taking a look at all of the data. So what Kelly was presenting was really around secondary and primary data. But then we turn around and we say, okay, partners, this is what our community said. Now, how are we going to start addressing the community needs that our community is asking us to prioritize? And so we do this through a variety of ways, but we start having conversations around what are your priorities and what are you hearing through your external networks. So we have 5 criteria that we asked our partners to weigh in on. And these things are opportunity, urgency, capacity, leverage, and momentum. And the reason why these things matter is if you're looking just at the secondary data, sometimes our partners, as well as Renown Health and NPH, we don't always have the resources to necessarily go after that very specific topic that they're looking for. But we know that it might be urgent. So this gives us a couple of options, and it could be maybe we invest more resources into that topic area, or maybe we are, or maybe we're tabling that to prioritize something different. So starting from the top, opportunity is just asking, is there opportunity in the community to address this need that our community is talking about? Urgency just means, is it urgent? Do we need to prioritize this above all of the other topics that we have? We recognize that all of these things are very important to our community, but we can only do so much, and we want to be very efficient with our time and our resources. Capacity, if we were to address this theme, do we have the capacity to actually take this head on? Leverage is a really big question in our community. Can we all work together, and are we ready to leverage our resources to address this topic? So can we work together? And then momentum. Are our partners getting additional resources to address this very thing? And so at the very bottom, you can see the total. Of course, mental health is the very top priority. Following mental health is our access to healthcare. And then we're looking at economic stability, and then maternal and child health would be another factor that we are looking at. This doesn't mean that all of the other items are not important. This just means this is what our community has the capacity to address at this moment in time. And so we're going to have some more conversations about how do we address these 4 health topics here in our community to figure out where do we start to lean in. They're pretty broad. So where can we put a fine point and start making some improvements here in our community?
For the board, should we take a quick break and then come back and
Sure.
I'd like to come back around is get the board's comments and feedback on what we just heard and where you're thinking the energy might, how this applies to organization. There are thoughts in the room as well. Maybe we take 10 minutes till 10:40 to 40. Does that work?
10:40 works. 2 minutes away from you, but I want. and recalibrate everyone. We are on item, are gonna table item number 8 to look at item number 9, just going in front of the board in March. So having said that, we'll come back and stay in item number 7 and look at offering an opportunity to have a discussion about the CHA and the information that we shared, correct?
That's exactly right. So amazing presentation. I'm not sure where Kelly just went. Be back, I'm sure.
Oxygen should be.
I think oxygen should be available.
Amazing.
And so it's always so much information, and then we always have to balance like providing the context and then enough time to get into the conversation. So the request of several of the board members was to make sure we have an opportunity to have a conversation about this. One of the most important things we need from today is, of the needs of the community, what is NNPH's role and how do we think about these prioritized areas as we're teeing up our priorities for the next 3 years. So we're gonna open up the space for conversation. Ray's gonna get a little bit more deeply, and then I know the board has questions, and staff, team and directors also probably have opinions as well. So this is the opportunity to say, work from our community, it's really deep work, so what? We probably have about 20 or 30 minutes for that conversation, and we will talk about the piece that we need to get to. So,
So going back to what Erica said at the beginning of our morning, this retreat is special in the sense that we don't always get to see a community health assessment. Every 3 years, we conduct a community health assessment. As you know, it takes a lot of time. It's very comprehensive. We're trying to look at every corner of our community to understand what is that overview of community health and where, as NNP, where's our role? Where do we lean in to improve health outcomes? And so it's special because all of these different data points are giving us an opportunity to look at health outcomes to determine where do we put our energy and our resources for the next 3 years. And so what we're really asking for is, we saw the data, we took a look at, we then, go to our community, ask them, what is your perception of what you just heard based on the same PowerPoint that you just received? What is your perception and where do you feel we need to lean in? And then we come to the board and then we ask you all, as well as our division directors, where do we have the capacity? Where is our role to address what we're seeing here up on the screen? So starting from the very top, right, we've got mental health, access to healthcare, economic stability, maternal and child health.
and I think just to get a little bit of a bridge, there might be some clarifying questions I think some of the board members might have had around maybe some of the data or anything that was presented. So as we sit with that question, let's get clarifying questions and then we'll go with the conversation.
Mine actually goes back to the survey group. I believe you said 694 participants in that. I was just wondering the demographics, how do we go about getting those folks involved in the survey? I guess I was just more wanting to see demographics. Were they from all of Washoe County? What was the makeup of, socioeconomic, everything? So that's kind of where
I'm gonna ask Kelly to come up and speak.
So that's a good question. And for simplicity's sake today, because we knew we were under that general time constraint, we've removed the initial breakdown where we looked at the education, we looked at age groups, gender, so on and so forth. So I do have those pieces of data that are available, don't have all of the ends and percentages memorized. But one thing that we talked about extensively, Nancy and I, during this community survey and our approach and how lessons learned would influence our approach moving forward, which is it's not a truly randomized survey. So I actually, just out of curiosity, we did a very, very simple statistical analysis to see, are we actually, is the survey truly representative of the demographic spread that we see in Washoe County, because we know that in the past, not being truly randomized, knowing there are harder to reach populations, and that can be very labor intensive of how you then purposely oversample certain populations. So we talked about that and we ran the stats, and I could easily give you if there's a follow-up, I just don't have the numbers in front of me, but I believe it was gender was statistically different from what we want to capture in the community. We were overrepresented on women and we were underrepresented on men. And then certain demographic groups were also challenging by race and ethnicity. I think ethnicity, so Latino and Latina were, I think they were actually matching. They weren't statistically different from the population, but there were some demographics. So there are a few key racial groups that we would want to better represent moving forward in that survey. But our teams did do a good job of promoting it on the media and trying to figure out strategies to really get as high of a participation rate as possible.
Thank you.
So, we do have some of that data. I don't have it in front of me, and we did have a slide that had all of that detailed. We simply removed it just for this presentation, but yes.
Understood. Thank you.
So this priority list, we're using how we're going to assign the assets that we have and how we're going to do this work. Why is this list, it's the number list, different than the pyramid you showed us through?
So the rankings and priorities that we do are essentially fed in by these data sources. So there are, for instance, in the primary data, there's hundreds of participants from Washoe County from the community giving their information to us. And so that information is done by the Hanlon method, which takes into those different feeds to do these prioritization rankings, which I believe from the exercise that was done, this is from the community forum exercise, which was post us telling them what the data is showing of the priorities based off of these different community components, but it's also a different sample of the community that is actively present and sees the presentation and then gives their own feedback into that presentation, correct?
Yes. So for clarification, we have two prioritized lists. They're in different order. We need to work from a list. Which list are we using? Are we using this one or are we using the Hanlon?
Is it not that, just to say it in what I think I understood was, we asked the community came back with the pyramid, and then you engage the community partners against those attributes around what's doable. So I think it's a step that that applies. It's the next step from the community to community partners applying against those criteria that then refine the priority list.
Thank you.
Is that,
it's like, yeah, it's like kind of, so yeah, I think a way to look at this is like the size and severity of the size and severity of these different health and well-being components are the child rankings, but then you essentially work with the community to talk about feasibility and how we can actually do quick and or long-term achievements to influence these different topics.
So pleasure.
Do you have anything? Sorry.
No, that's okay. Pleasure of the board though. So the slide after this is the last step of the prioritization. We could go back to the pyramid if that was easier, but okay, we'll go with it. Okay. Sure.
Sorry. Can I ask a question then? I was just wondering, and I may have missed it when you were talking about the stakeholders and the different folks that we were involving in the community. Did we have housing authority? Did we have educational participants? And even like economic, EDON and stuff like that? Those were all a part of the group?
Yeah. So for a community forum, we reached out for about a month to ask our community partners to come and join us at the table around the community health assessment. With Renown Health's help, they also did their own outreach to make sure that we were inviting their partners to this forum. So when we say community partners, we're talking about everybody from business to academia to nonprofits to housing. You name it, they were there in the room. So our MCOs were there. Kelly also shared the very first slide was our steering committee. We're also vetting all of our indicators through our CHA steering committee to ensure that we are looking at the right data sources. And we're doing this, making sure that we have housing representatives, academia, physicians. We're trying to make sure that our scope is comprehensive so that, again, we are looking at community health as a whole and not just through one lens. So we're doing it through a variety of factors in each step of this process.
Marty, do you have anything? Brown, do you have anything?
Thank you for clarifying everything on community partners, public safety, law enforcement. Every time I see violence, prevention, and crime, are we stepping into the wrong world? But glad to see that there. Thank you.
A quick comment. So both are very comprehensive processes when you're seeing the two rankings. The chart itself is what Dr. Watkins presented, is that it took us 6 months in partnership with Renown, where the comprehensive secondary data, primary data came together. And that, along with our steering committee, came out with the 8 prioritized rankings. Then we went to the community forum of almost like a democracy, where people in the community where they have capacity to make a change. So that's why it looks different. It's where they're focused on, where they think the change should be made, versus the other one is our strict data collaboration and our strict conglomeration of everything together. And that took 6 months to complete, which is the chart rankings that you saw.
Thanks for clarification. Dr. Danko, do you have anything?
I'm okay. Thank you so much for asking.
I wasn't sure what you said, but if you have anything, you're welcome to share. If you have any questions, comments.
Oh, no, I said nothing from my side. Thank you for asking.
Okay.
Thank you.
I have a couple things. First of all, thank you, Dr. Watkins. I'm serious, like the succinctness and the depth of information you covered in such a short period of time was amazing. And kudos to everyone, Renown, everyone who helped, because we're just seeing the end result of it. All of the data that gets fed into that and all of the meetings and hours of the contributions that have been made should be recognized and are greatly appreciated. Having said that, I did have a couple questions as well about the steering committee, because as an example, and I'm just throwing out, when you're looking at things and thinking about all of this, and I may, again, not taking away from Renown. Renown is actually a % partner in this, so thank you to Renown. Thank you. Is even including Dr. Amy Hines Souther with NACO, and I don't see her on this, and I think that is really missing an opportunity, especially because of NACO's not only Nevada NACO, but national NACO, and representing 369 counties across the United States of America. Having said that, I do think that there is also opportunities with the CHA to help drive and blur these silo lines. And here's where I'm going. I would love to see, and if you've already done this, I will apologize that I'm just not aware, but I think the District Board of Health should be very aware of what's happening with the sequential intercept model. The sequential intercept model is touching almost every single one of these points, every single one, whichever list we want to use. And I think understanding how the sequential intercept model and the CHA can help drive that. And I think a lot of people don't, is everyone familiar with sequential intercept model? Okay. Oh, there we go. Brianna, do you want to take it?
So I don't know if maybe everybody knows about the sequential intercept model, but to kind of shorten it up, our sequential intercept model is actually supported by our last community health improvement plan, as well as the work of the behavioral health system. So the sequential intercept model is the idea that we are intervening with those who interface with the juvenile system and making sure that they get the intervention that they need before they get to a point in which maybe an organization should not be intervening with people. So it's to try and give them earlier supports at an earlier time period in which they interface with the juvenile system. Is that?
I'd also extend it to not just youth, I'd extend it to everyone in our community. And mental health is the major contributing factor, and seeing how the sequential intercept model and taking this CHA data and sharing that with the folks that are supporting the sequential intercept model. But I think the board, it would behoove all of us to have a presentation about the sequential intercept model and really looking at prevention and identifying prevention long before it goes to a jail-based solution, which is not the solution. That is not where we should be essentially trying to look at treatment, if you will. So I will stay off the sequential intercept model. As you can tell, I feel like I should get a tattoo, a SIM tattoo. If you see me get a SIM tattoo, you know it stands for sequential intercept model. I think having Judge Walker speak at that is something I'd highly recommend. The other thing that I'd like to share is I do think the CHA, again, blurring lines, I think the CHA, and when is the results coming out?
I think our goal right now is to have the at least final draft by June, but we plan on publishing pretty shortly after that. That's our tentative timeline right now.
Is there going to be like a community forum or anything to actually talk? Because imagine going through, even if Scott, who does a great job with social media and all the channels, sends that out, they're going to need you, Dr. Watkins, to come. But I do think even chunking it out, because it is so big. And I think maybe chunking it out and trying to share what factors are, because I'm sure that this touches everyone in one way, shape, or form, whether it's the mental health or whether it's the violence prevention and crime and everywhere in between. So I would just like to offer that as a suggestion and recommendation for consideration.
That's great, because the CHA itself is hundreds of pages. It's a lot of information for people to synthesize, and that's something that is typically, at least I can speak for my program, we very much so talk about community engagement and how we continually have those feedback loops, not just with our partners and internally, but also how the community is able to understand and see how it impacts them and give their input. So I think that's something we always try to maintain and focus.
And honestly, I know that time is always a factor and everyone's balancing a lot. But the reality is, maybe you could do the CHA tour and go to the Eat On Board meeting and go to those folks who are part of our, I'm just picking Eat On. You said Eat On because I was thinking too, and housing. It touches every single aspect in our community, not just SIM. And so maybe there's an opportunity to think about really how they then can think about how they can be the solution as well. I think it also ties into the financial aspect of the budget and how that can be leveraged, so resources can be leveraged and stretched to accommodate as much as we possibly can in various ways. So I wanted to throw that out as well. The last thing on my notes, I had more, but I'm going to restrict it to this last column. I was writing a lot. As I was watching you not even take a breath, like you were amazing.
I was in that 20, well, I don't know if I was in 20 minutes, but I tried to keep it.
You did a great
I tried to keep
job.
it close.
I just returned from DC attending a National Association of Counties legislative conference, and the current administration's Director of Health and Human Services was a guest speaker and really gave a lot of stats. And one of the things that I think the CHA fits into even that is looking at, for instance, the health threats of children. As an example, I believe there are 5 states right now legislatively that have adopted, not been mandated, to have like the WIC program not include soda as an example. And they're seeing results of not having sugar be a part of, unfortunately, due to the economic factors that come into play with those recipients of WIC. as an example. I'm not just picking on WIC, but I just think those two are also important. And so I wanted to throw that out because there could be some even legislative opportunities to help that maybe we can bring some of these things down and not always be the leading. Your indicators on red were, in some cases, I don't have to tell you, we're sometimes more than double, not only Nevada, but the national average. That should give everyone pause. And what should we be doing? The last thing I'll say, and I'm going to call the president of the Washoe County School District and many other folks in other school districts, because they're also looking at grants to help with nutritional programs and really mandating. So it all ties in, doesn't it? And we're here for the community. So I wanted to throw that in as an example that you might not be aware of some of this. So there you go. Thank you so much. Anybody else have anything? Oh, Dr. Huarte.
Yeah, I was just going to comment that the mental health ties into the substance abuse, health risk, and violence prevention and crime.
Yes.
So those are all tied to that. And the other is the economic stability. If people are homeless or don't have the resources to take care of themselves, we have all of this fallout that comes down through the.
Did you see the SIM model? I think you're going to find it very
Well,
interesting.
I mean, there's lots of models that inform us and they help us understand complex data sets. But I think just seeing the mental health thing to me is tied together a whole bunch of other things, and the economic stability ties in most of the others. So I think this is a pretty good alignment of what we need to be looking at.
I would just extend that to the board. You know, we're looking at these priorities to hear from you. Where do you feel that our role as an NPH should be? Do you agree with this that we have? You know, we try and be very intentional with our CHIP. We know that we can't address all of the 8 themes, and so we try and be intentional by addressing the first 4. That doesn't mean that we aren't going to address, you know, health risk and early detection, the other things. We can absolutely do that, but our CHIP is really focused on the top 4 themes so that we can leverage our impact with our community partners and resources so that we are intentional about the time that we have over the next 3 years to actually see health.
Driscoll.
So kind of a general question from the standpoint of, this is what the community says that they believe are the issues and what the services they'd like to see us perform. How does this relate to what we're actually doing as the health department and the services that we're providing to the community? Is there a conflict between what we're really doing versus what they think they want?
Yeah, so try and balance, right? So we understand that our role as an NPH, we are likely not going to provide therapy for mental health services, right? But we can support mental health in other capacities. We can provide an investment to say, we know that this is going to change public health infrastructure. We are going to give, let's say, the SIM, you know, resources, and maybe be the convener of that conversation to ensure that we're addressing mental health. But that is to the extent that we're not going to start doing outpatient therapy, because that's quite not our role, right? We can address transportation. Transportation has come up a lot in our community survey. You know, people cannot get access to healthcare because there's lack of transportation, specifically out in our valley areas. We are not going to become the next RTC, right? We are going to invest in the transportation system. We might be able to say, okay, we need to do a little bit more thinking about what bus lines are put in, you know, out in our valleys, or maybe in some of those areas that surround Washoe County, so that people can come into the city to get access to healthcare. But we certainly are not the next RTC. That's where we draw. So we try and strike a balance between, if mental health is prioritized by the community, how do we be thoughtful about an NPH's role in addressing this, but stay out of the lane of providing those direct services like therapy? We could be the convener, absolutely, and that goes a long way. I mean, you think about the crisis response system, NPH was the convener of that conversation. We now have a crisis stabilization center 4 years later. That was an NPH's role, is the convener.
I think the other value here, to address your question, is that it informs outside agencies where they need to be looking, directing. So you're talking about bringing people in, but they're building emergency rooms out in the periphery so that people don't have to travel long distances, so the services are more available in their community. So this is not just about what informs us as the public health board, but also informs our stakeholders and partners in the community about where they need to be looking and where they need to be doing. So I think that's the other value of the community health.
Yeah, and if I may, just to add, I think that wraps the bow about what I was trying to say. And that's what the charge for that I mentioned. That then allows not the responsibility of public health to execute and deliver, but to actually provide the framework that the data helps to drive. This is what not only the community says, this is actually a priority. And then those folks, to your point on the Crisis Stabilization Center or the SIM model or others. So it allows essentially those that are in that space to actually have even more resources and data so they can write the grant or they can actually look at what they need to adjust in order to meet whatever the particular criteria is. That's why I think the CHA tour, I'm just calling it the CHA tour, would be really, really great. Because then you're just having Dr. Watkins go out and just share this information to those bodies who are delivering it, not that it's on health to execute. And who knows what that benefit might be to our community as a whole.
And to that point, just to maybe tag on to that and see where we might bring this conversation today. With the direction I think it would be very helpful for staff is, did these four, are those four rising to the top from where you sit as well? Or would you like to see something else highlighted, so to speak? And then I think the tools that the team has to facilitate and come back with an actual plan is the foundational public health services inform direct service. That is the role of this organization. And then supporting or secondary through convening or other such means for things that are up here, but that are not necessarily direct service of responsibilities or quite frankly, affordable with the resourcing that the organization has. But I think those are the kind of the guidelines I do believe that exist in order to help make sense of direct versus supportive or secondary service, if you will, or secondary convening, et cetera. But I think what matters is these four are the ones that rose to the top from the process. Does the board concur with that, or would you like to see anything else bolded? Sir.
If I may, I thought that having the maternal child health at the bottom of the priorities was a problem. And so I'm glad to see that in the transformation and with adding additional input, you were able to raise it up to 4, because I see single mothers struggling to earn an income. They can't nurture their children. This relates to behavioral health, health problems, getting in trouble with the law, all of these things, the gangs, all of this stuff stems out of these kinds of stressors. And so I think moving the maternal child health to a higher priority level makes a lot of sense and ties together with all of this, the mental health, the economic stability, the access to healthcare, all of those things are tied together. And I, from my 50-year perspective as a physician, tying these things and working all of them as kind of a unit problem is going to yield the best results and the best stability over time. And I think that with all of the stressors that people are experiencing, it really drives a lot of the problems that we're seeing.
I wanted to ask Dr. Danko just because. Dr. Danko, do you have anything that you'd like to add? The top 4 are being asked. I'm sure you can see everything okay, I hope.
Yes, I can see everything just fine. No, I don't have anything to add at this point. Thank you.
Mr. Anderson.
Can you help me understand the relationship to the CHA versus the CHIP? And I mean, I know they're linked, but could you help me better understand
Just
that?
put music in between.
Never mind, she answered.
Yes, so the CHA is the collection of data, And so we do that through collecting secondary data. So that's all of the indicators that Kelly talked about. There's also a data synthesis pack that you have in front of you, some of those data indicators. So we're looking at health outcomes. And then we're also gathering primary data, which is going out into the focus groups and surveys and key interviews to understand from our community all of these themes, all of these data indicators, your health outcomes. Where do you feel agencies like Northern Nevada Public Health, Renown Health, who are bringing our community together to improve public health outcomes? Where do you feel you need the most help to improve your quality of life here in Washoe County? That is the CHA. We transition data into action through the community health plan. And so our community health improvement plan is just taking that data and saying, this is what we are prioritizing as a community, focusing on these top 4 priorities. And this is how we are very specifically going to measure health outcomes and improve health outcomes through very targeted initiatives like the SIM, crisis response, the crisis response system, the 5210 Healthy Washoe program that addresses physical activity and nutrition, Mama Care Kits for maternal and child health. We talk about those very specific interventions with our community partners to uplift the priorities that you support. So that is what the CHIP is.
Just to add on that, it's always a good example. So previously we had the last year's CHA. The only difference between the last CHA that we saw is economic stability came on here. That's a priority that our community came out. And I know we all know the reasons behind what's occurring. So that's the addition. So previously, 3 years prior, same thing, we developed the CHA, went to the community, and then we developed the CHIP from that. So our previous CHIP that Riona has brought to periodically is we invested in the SIMS. We invested in we shared cost of one employee to help. Getting the name of that, and what program was that for mental health?
So
behavioral health.
So the Office of the County Manager's Office, they have a behavioral health program. And so we are helping to manage the crisis response system through an employee who is managing that process. So we are contributing. We are one agency that contributes to making sure that that structure exists.
5210, the food access program out there in the community, healthy corners. Those are things that previously came out of the previous CHA, and then we made what's the priority we're getting in the community. That's where we invested over the last years.
Okay, awesome. Thank you. I appreciate helping me understand. I knew they were linked, but I appreciate you going a little bit further.
So any other comments from the board about us, the larger group taking forward these 4 as we're moving into the next 3-year planning cycle? Sounds like we have support, generally speaking. Nope, I just want to make sure that everybody's added their thoughts.
So a clarifying question in the standpoint that within the top 4, there are some things we specifically do. There's others that we would advocate. What keeps us from straying away from the advocacy role that we're supposed to have and not dipping our toes into something more that we shouldn't because it's suck up resource? How do we control that?
And that's a good question. So we have the foundational services that really keep us aligned with services. And we really have to use that framework. Can we resource this or not? And it's NNP, as an NPH, the convener, we can say we can't necessarily take on this, but we identify a partner in our community to address this issue. And then we still put it in our community health and we still report on it so that you all know how progress looks like. But we usually identify another partner to be able to do that work if we are not resourced to do that thing.
I think just echoing that, so that was one of, I think, slide 8 toward the beginning. But those are the 5 areas, if I'm not mistaken, correct? That are those foundational public health services, which is where everything starts from a core service perspective. Of which few of those are directly aligned up here, not. So if the board is supportive of that, then the team will take this back and use the foundational public health services as core programming, and then understand that other things would be through convening or advocating.
to add to that, so the CHOD chip is core for us. That is a requirement. All public health across the nation do CHODs with chips so we can inform our community. Many times adjacent systems come out that we do not directly address, but we are part of those systems. So it's where can we make an impact in the system to overall improve our community, but we don't have to invest in it or put our resources into it. And it's really that collaboration and communication.
Yeah, just to clarify, some of the other items, this is the prioritized community needs is how I see it. The reality is we could probably take some of even 5, 6, 7, 8 and talk about what there's compliance that actually may be statutorily required for some of those items. So I'm not looking at it from that perspective. I'm looking at it with all the data, how it was compiled, both primary, secondary, all the hundreds of hours, if not thousands of hours that contributed to this coming out to the top 4. So I think separating that to your point about not bleeding in or having, creep into getting into an area, I think it's actually clear within the organization on what that differentiation is. So, yeah.
Just like to kind of go off of what Mr. Driscoll was pointing out. And I'm just wondering, do we routinely check ourselves to make sure that we haven't inadvertently gone down past where actually a community partner is better suited, better financially, logistically, whatever, better suited for that niche?
So we come every 3 months, correct?
Yes, so I come every year to share with you the annual report for the health improvement plan, and we discuss all of the initiatives that are included in the report. And then also when we're having all of our committee meetings, I'm also taking a look at our to say, does this align with what we do as an NPH? We're not resourced to do that thing. Again, we're convening with other partners to make sure that they take on that role. So there are a lot of times where we're just a partner and we're just making sure that people are coming to the table to understand that we're all operating using the same data set to measure health outcomes, but we're not taking on that. Crisis response system, I think, is a really good example of that. We are not resourced to stand up the crisis organization center and all of the different factors, the 988 system, that was for another partner, but we absolutely were the convener to make sure that all of those stakeholders were in the room to determine how that system was going to operate here in Washoe County. That was our role, but we're certainly not going to be a crisis center.
Transition into finance. As we're moving into a budget, and one of the 5 financial principles I've listed today is $500K. We used $500,000 that we used to invest in these systems, not over for us to do, but it's a discretion board for us to take that and invest in those systems so we can make an impact in addition to working with our partners and all those points. So that is come up again. That is one of our financial principles I'll be discussing on today. So we want to and talk more in depth. But then we do our budget, what also affects what is our capacity and ability to really put our bang for our buck.
Yeah. You get it. You did. That was nice. Thank you for the time on that conversation. And again, we could have all afternoon about it probably. It's not rich. But that's really good direction. That's what we're from that topic. The 2 other topics that I just flipped through, we'll come back to another board meeting, and
we're going to close item 7, and now remember we're tabling 8, looking at having item number 9 come back in March. So now we're on item number.
Just to frame it up, we are hoping to take action on this item, so just knowing what we're doing on that.
Okay, thank you, everybody. So I've got a full slide deck inside of the attachments. This is a truncated version. I'll go through it really quick and just highlight those things that I think are the most relevant areas. Starting with our org chart. So we've got 194.99 positions at the moment. We're at about 165 that are currently filled.
We've been managing our vacancies as a way to deal with our budget. And as I go through this, I'll give you the punchline in advance that our expenditures are increasing faster than our revenues. And we're going to have to address this over the next couple of budget periods. And I'll explain some of the details as we get into this. So just as kind of a general overview, this is the fiscal structure for our revenues. So there's a good chunk of what we get that comes from grants that's been changing over the last handful of years fairly dramatically. We've got state funding that's sort of a new source of revenue for us that seems to be relatively stable. Fees from environmental health services and air quality management, as some clinical services. And then we also get a county transfer. So on the expenditure side, same thing. There's about 4 things that are particularly relevant to us. I'll keep saying this over and over again, that salaries, benefits, overhead are compromised about 90% of our budget at this point. Most of the other things that exist within the budget, we have some flexibility within to make adjustments, and that falls within the service and supplies category, but salary, benefit, overhead are the major drivers of our budget. This is the source and use. So this is our reflective budget for the close of fiscal year 26 as well as 7. And then there's an above base ask for the county that shows an additional $1 million ask in transfer to increase our total transfer to an $11.5 million from local funds. Know that this reflects worst case scenario. This makes the assumption that our entire budget is spent out. So we have authority and we don't necessarily spend that authority in each one of those areas. So this is reflective of the full authority that we have at this moment on the revenue and expenditure side. So we know that there are places where the revenues may be understated. There's places where the expenditures may be overstated. There are some unique features inside of the budget that I can get into on some of the later slides of the way that we booked the public health funds that came from the state this time. But the general trends are showing us to that salary benefit overhead issue that most of the jurisdictions are dealing with at this time. So this is just a summary of the base request that we have, that we put this into the financial system, and we've asked the county for an additional $1 million to address our shortfalls at the moment. This is a reflection of our full revenues, and I'll get into the details of this. It's kind of a strange period to choose from 2019 through 2027, but I chose this because 2019 is the last budget that we have that doesn't have COVID and ARPA funding. So the little dance in the intervening years with the total revenues is showing that we've had a number of lots of money that were put into our budget to deal with both COVID and ARPA activities. So getting into some of the specifics. So this is our intergovernmental revenue. The vast majority of this is federal grants. So some of those federal grants come straight to us from the federal government. Others flow through the state to us. But overall, between 2019, COVID time, up to 2027, we've had about a 24% increase in those grants. So those grants have increased in dollar amount over time. But I'll show you when we get to the expenditure side that our expenditure increased by about 60+% over that period of time. So the grants aren't keeping pace with the cost of the services that we provide. And again, that dance in there between 21 and 26 is reflective of all the ARPA funding that occurred over there. So this is licenses, permits, charges for services. So some of this is in air quality, some of this is in environmental services. And some of this is inside of the clinical areas. So we've got some increases, 2019 to 2027, 41%. We come up each year by CPI. In the intervening years that we don't do a full fee study, we do a full fee study every 5 years. There was 1 year around 2023 that we decided to forego CPI because we had so much cash on hand. And that CPI was about 8%. So if we take the full CPI over that period of time, we would have brought in about 49% increase of revenues over that period of time, but it's still not quite keeping pace with our expenditures. This is the general fund transfer, same period, 2019 through 2027. For 2027, this reflects the $1 million increased ask in the above base. So over that period of time, our intergovernmental, our transfer from the county has increased by 21%. So this is the expenditure side. Same things. This is an overview of 2019 to 2027. The dark red is the salaries, the middle is the benefits, and the light blue is the overhead, and then the pink would represent our services and supplies. And then the dark blue at the top is really just reflective of capital, which is always tied to some revenue source that we brought in. So those salaries and wages over that period of time have increased by 71%. This is the thing that's driving the cost within the department. I know that it's becoming a recurring theme that we'll talk about government at the state level and the local level and even the federal level. This is pretty common that inflationary pressures are hitting us. Out the other side are increased salaries. Same on the benefit side. We've seen a 75% increase in benefits over that period of time. Some of this is reflective of OPEB and COVID pandemic created some fascinating things in OPEB, and it seems to be leveling out over a period of time, and probably over the next couple of years, the dust will settle on it, but it's trending the same way that salaries are trending of 70+% increase from that pre-COVID time to this moment in time. This is the overhead. This is what we pay back to the county for the services that they provide us. This is technology, this is the manager's office, this is human resources. And over that period of time, it's increased by 132%. And I'm gonna put a caveat on there that this is an estimate based on best possible information. I have more information. We assume it's gonna go up by 15%. In this case, it went up by 11.2%. So there's a minor adjustment that I need to make in this chart, but it's gonna be immaterial for that 131, 132%. This is our services and supplies. So when you take all of the other activities out, when you take the salaries, the benefits, and the overhead out, this is what's left. This is the fuel that we put in our cars. This is the biologicals that we purchase for the clinic. This is all of the activities that we do on a day-to-day basis. And over that same period of time, we've had an 11% decrease in our services and supplies as we're compensating for these increases in salaries, benefits, and overhead. So this one, there's a little bit of sawtooth in here, and I'll explain this a little bit. So this same period, 2019 through 2027, and then some projections going out to 2030. Over the course of COVID, when people were billing towards those grants, we were banking money into our health fund, and that fund continued to increase over time. Eventually, we ended up with in 2024, we had about a $2.8 million shortfall. We created some efficiencies. We backed off on positions. We tightened up the ship as tight as we could. That reflection into 2025, if you take out the sawtooth. So what's happened with the sawtooth here, the 128,000, is that we got SB 118, which is the first time that the state invested in public health activities. That revenue was booked in 2025, and it can be expended out into 2026. So the revenue is reflected in 25, and about 1.7 million of that will be reflected in 26. So there's an underrepresentation in 25 and an overrepresentation in 26. But if you look at the general trend, we're going backwards by roughly $2 million a year, which shows that impact of the salary benefit overhead. So that's the place. And even though we're compensating on the revenue side for the CPI increases, the expenditure side is moving faster than the revenue side is. And this is a reflection of fund balance. So the same thing, it's just showing the money that we banked over the period of COVID. So prior to COVID, we were sitting around $7 or $8 million a year in the health fund. That continued to increase as we were billing to grants, and the health fund inflated over a period of time. Now we're using some of those funds to compensate for the shortfalls that we're dealing with. And that shortfall, you can see, is following that same trend of roughly $2 million a year of salary benefits overhead that we're trying to figure out how to compensate for at this moment in time. Showing that we'll hit our minimum reserve somewhere around 2027, 2028, depending on how revenues come in and depending on how many expenditures we can control. But somewhere over the course of that 12, 24 months is the point where we're going to have to have serious conversations about how we address long-term sustainability for the department. And I won't go through all this. I can dive into it if anybody's interested in particular areas, some of the assumptions that I made over the course of this. I think that they're relatively straightforward. The only thing that will cite again is salary benefit overhead or those things that roll over the department and they're impacting our budget. And the risks, same things. I won't read all of this to you. I know our time is precious, but if you have specific questions, I'm happy to get into the nuances of the risks that we have over the next couple of years. And I believe that is it.
Thank you. Have any questions? Would you like to add anything or?
First, I want to say thank you to the board as well as our county partners, those jurisdictions on working with our budgets over the past year. We met monthly and will continue to meet monthly with county budget staff, and so they've been a wonderful support to us on being able to address that and help to really fine tune our budget and looking at our risk and overall components of it. And then this is to understand too that this isn't just us. We understand all our communities and across the nation, our local budgets are facing this. And so we're the best partner as we can on that. And we'll always move forward basing on data and our core services and what's priority for the community as we have to trim up some. But you know, it's always, we don't want it to be the sky is falling. We understand that we've been here before and we're here today. So same thing point. We are still here today. We plan to be here next year and the following years, and you'll find where we do what continuing to protect and deliver our mission to our community. So I look forward to being partners with you on these points. We know it's not the prettiest when we look at our numbers, but it's that slow incremental process, I believe, as we work through this with our partners in the county and addressing those points to continue. And it's modest, but it is a good point that we worked with the county and $1 million above the base. And we continue to work on them and continue monthly access with them in order to address as we.
Thanks. Questions? Anyone have questions? Dr. Danko, do you have any questions?
In the budgeting information you're showing, it's assumed that our friends at the county are going to inject the funds needed to get us to where we need to be. Is that, I mean, out of all the slides that we looked at, that's what we're counting on?
I think that we are having ongoing discussions about what that means and where it's going to land. We've been having those discussions for a couple of years. We're doing what we can at this moment. To me, that $1 million represents a good faith effort. It says that we need time to see the dust settle inside of the COVA and the ARPA funding and see what the trend really looks like. This budget is really complex to see when you start getting into the nuances of revenues hit and how they offset some of the expenditures. But I think that $1 million really does reflect us working in good faith with the county to say, yes, we need to open up our books. We need to look at the details and identify those places that we need to be made whole. I think that some of this is tied to the federal conversations as well, that I think that we're reflecting the toughest grant environment from a public health perspective that I've seen in 22 years. So it really is, are we going to make changes to those programs that are grant funded historically, or are we going to start addressing some of the infrastructures and looking at different ways to approach those activities? So it's going to be, I imagine, some combination of those activities.
I have a question, just in terms of the projections that, you know, how. In that preparation, I wonder if there's an opportunity, and I've been doing this a long time, so it's really just asking to look at a priority-based budget, to look at what are the compliance requirements, to look at what is, this is what we have to do, and this is what we don't have to do. And looking at that in a priority way with compliance being its driver in preparing as we move down this path of uncertainty. Because as you've mentioned, it's not just actually us, it's not just the state, it's the entire nation. And so I think just in planning accordingly and adjusting accordingly, I wonder if we could think about having opportunities of more discussions as we plan and forecast. And then what does that look like so that when the decisions that may come before the board, that we're well prepared for understanding why we are here, even though you will know because you're well informed and you do this. And thank you for putting all this together. I think going through a planned process and path will help, because I don't think that the expectation of delivering to the community is not aligned with what we're required to do versus what we're required and we do. And so I think there, as we travel down that, there's also an education opportunity as well in the event that some tough decisions have to be made. So instead of having it, like I said, come for a decision in a planned way on an agenda, that we have a plan and a process to get there. And if something, if we find the money tree, or, you know, like, then that can be adjusted too. But I do think priority-based from a compliance standpoint is really a critical. I'm saying what I'm saying at Washoe County as well. So I'm not just reserving it to just this position that I'm honored to serve on. But I would welcome that opportunity that is available.
Absolutely. And
having briefings, I'll just add one thing. And I think having briefings, because in a business meeting, we're very constrained, and I think having briefings to understand the depth of it will help all of us to better support all the great work that's done here.
Absolutely. I appreciate the feedback, and I think that we have a priority matrix that we put together, and I think that we can tie those pieces into the budget. So I think that's likely our next steps.
Thank you. I appreciate it. Anything else, Mr. Driscoll?
With your permission, before we finalize and decide what we're going to do about the budget, if I can just jump ahead to the next agenda item, the very first proposed principle. It is suggesting if we were to approve these proposed principles, that our ending fund balance would be at least 17%. This budget that we're going to be asked to make a decision on is only 13.9%. So I guess I'd like to understand, since we're having this proposal of what we'd like to do, and then we have the reality, how are we going to tie those together if we were to approve the proposed principles under this budget?
So on that point, yes, so the county has set their priority for a cash end balance of 10% to 17%. So we chose the high end of the 17%, and this can be amended today, but we chose the high end similar to take the example of COVID, or our pertussis outbreak right now, or if we have another outbreak. So for the first year of 2020, we floated over more than $50 million to maintain COVID, right? So it's always keeping a little bit extra cash on hand to do that. So we took the high end of it. It doesn't mean that it sets a principle. And so being lower than that, I think it goes to speak what Chair Androla said, is that we have to make some.
I'm vice chair. Chairs, don't put me in that position.
Vice Chair Androla had said that, it's just that we may have to make some decisions. So that helps us inform. We have that principle. We know we now are below 17%. So we need to apply our principles, get back to that as close as we can. That may mean some hard decisions. So that just helps guide the board as well as us as preparing finance to say that, okay, we are now below 17%. We need to address this. We're at this point that we need to recognize that, and we need to find those solutions. It's ultimately what it's saying as a principle.
Now, I have a follow-up. What's the statutory requirement for balance, fund balance?
It's by policy, it's 10 to 17%.
It's what it's
10 to 17%.
Oh, yeah, there's a range, right? There's a range. Yes, so there's a range from 10 to 17. And so we're within that range statutorily. And so I'm going to stay within the scope of the authority, this agenda item. We're moving, and I'm looking at the attorney. I try and not have the attorney just share, wonderful things about how her day's going versus saying that I'm leading into an agenda item that's not, we're not at. So I think there's an opportunity when we get to the next agenda item to talk about what that says. And, unless we want to pause this, ask for legal counsel if we can move to pause this, come back, look at the guiding principles first, then we'll close that and then go back. That would be my recommendation in facilitating this meeting, and staying within the compliance of the rules.
For the record, you can take your agenda items out of order. Just please be clear on the record which item you're considering.
Yes. So I'm getting the feeling, unless there's something that we could table this item for the moment, open up discussion on the next agenda item, take the appropriate action, and then come back to item number 10. If that pleases the board, that's what I'm going to propose.
Looking for a motion.
Nope, you don't need a motion to do that. I'm just, if someone had a problem with it, then we could have it adjust, but it sounds like we're going to move now. We're going to, just for the record, we are going to pause or suspend. I don't know what the legal term would be. What would you say, Counselor?
Defer until a subsequent item. After 11, we're going to take the items out of order.
We're going to take the items out of order. Item
Bring
number
10 until after
we're through with items. So we're going to open up item number 11. So having said that, Dr. Kinsley, you are up for the presentation, discussion, and acceptance of the Northern Nevada Public Health Guiding Financial Principles to align the board on long-term sustainability, responsible stewardship, investment strategy, and mission-aligned resource allocation.
So we bring before you today 5 guiding principles. It's our principles that allow us to be able to have the direction of the board, that also help us when we are developing and managing our budget, to make sure we're in line with not only mission, but with the board's perspectives and as well as principles of how we use our budget. So these 5 points before you, and I believe at your discretion, if you'd like to talk about each one, or I could go through and just go ahead and give a perspective on each of the 5, or divide them up. So I just like to take your direction on that, on how to discuss them.
I would, just in the spirit of everyone being prepared to come to this meeting, if anybody has any specific questions at this point for any of these 5 items. Dr. Danko, do you have any questions?
I do not have any questions at this time. Thank you.
Great. So I actually have already shared this with Dr. Kinsley in a briefing that I had, so I'll just fully be transparent and share it with everyone. I believe that principles are certainly wonderful, but policies have what I would call a direct place And item number 1 is not a principle in my opinion, it is a policy. And I believe that that policy should be agendized. I believe we should have a range that statutorily falls within what's already in law. And to make it at least 17, I know we could get into semantics, but 10 to 17 is the range. And so from my perspective, just my perspective, I will, follow the vote that we'll be taking as the board. I would like to recommend that item number 1 be put on an agenda for a policy of 10 to 17 that falls aligned with the compliance that we're required to fulfill. And for me, I think the rest of the other 2, 3, 4, and 5, I think are fine for a principle, but that was the comment I felt compelled to share with it.
And maybe just as a context on this too, for background as well, is the notion about teeing up some guidelines for decision-making prior to potentially moving some of these into actual policy to see if to try them on before memorializing them. The first one's is a bit outside of that commentary because it is a current policy and requirement, so.
Yeah, and that's why I brought it up, because it is a policy, in my opinion. I also think that as we're moving through these guiding principles, that as I already mentioned in the item that's now been deferred, that I'm not going to talk about in depth, is that we need to look at priority-based budgeting, and we need to look at the compliance. Those are the financial guiding principles that we're moving forward. That, in my opinion, should be included in here, especially given that principals do have that agility to move as needed, certainly coming before the board, but not with the depth of policy. So I would like to see an additional, so item number 1 would go to a policy agendized, that's my recommendation, adding another item that would look at guiding priority based with compliance being added. I would like to add.
Go ahead, sorry.
No, go ahead.
I think I was just gonna tag in on that. I think number 4 is the intent, the spirit of number 4 kind of starts to go in that direction, but I'll leave that or.
So I would say, yeah, and some of these too, I want to be transparent with them too, that we're not, we're putting these principles so they guide us. Will they guide us towards policies? And as Eric outlined, filling them out. So just some challenges like, what's the real world? What does this mean? Translate to. So number 2, when we go 100% cost recovery, this is where public comment will come in and say that, well, 2 years ago when I was a restaurant, I paid $600 for my fee for the year. It's now $1,200 a year. And so that's what it translates transparent, right? And especially when you go CPI. So we affect small businesses. We expect the economy of our community as a whole. We do perhaps create some barriers, but at the same time, it's 100% cost recovery is a valid target for us. And that's why we put in there too, that we're at least every 5 years, we're doing independent studies. So it doesn't want us to be us saying, hey, this is the fee we think it should be. We're having the independent study come in to verify that. And so we're always trying to best align that, but it does put constraints on our community. I just want to be transparent about that. Next is an NPH shall dedicate $500,000. So this is where we have previously, with our previous CHIP, we dedicated $500,000 to invest in our community. We did it into mental health. We did it into food sources. When you get into budgetary crises, it's kind of like building a new capital project, and our community will say, well, should this not be invested in your services over a building? So we do get into that. And so there is perhaps a point in there that we have to, do we cut back that $500,000? Do we taper it down? Do we put a limit on it? But this is just the beginning principle to that we have to address. We have our staff will say that, when we go into priority-based budgeting, which we have aligned on those points, there'll be hard points on there, and it will be hard for staff to say that we're going to continue to invest in an adjacent mental health system over our core function. So there's challenges there, right? We have to recognize as a board of the reality of it. Same thing, so you go into what our core services is, that sets us there and that guides us, but that also means when we do our priority basing, those things that are priority based are challenging. So one is an example, mosquitoes, right? It's down on the bottom. Suicide prevention is down on the bottom. You know, these are priority bases that perhaps we will no longer we will pause investing in until we are better situated to be able to reinvest back into those. So that means those are sometimes those hard decisions that we will have to face on those ones. So this is just being, and then we already, number 5 is already there. We practice that on a monthly basis, but it's just also how the board receives information. I just wanted to be transparent on all these points. We realize there, but what does that translate sometimes into the real world? But and this is something that we have spoken about, especially number 3 with the 500,000 spoken in depth with our directors. We're in alignment on it, understanding that there will become a point that we would have to pull back on it, which is challenging, and because it invests into systems and truly makes an impact in our community. So it's the capital project versus the reality of our services. So these are great principles, but we do feel that because we are in constraint right now, we need principles to make sure that we're moving forward correctly.
And what we need from today's conversation, we don't necessarily need action, but we are seeking direction. And I'm also watching the clock a little. I don't know if the board is to stay an extra 15 minutes, but we do need to come back to the item that we've. So Vice Chair.
So you don't need action on these?
Do not need action, but we would like feedback. We would like feedback.
Okay.
So Dr. Kendley, per your just conversation you were just having about the 500,000 for the chip, seems to me that the language in the principle for this line should be may instead of shall. The other one, shall is appropriate because that's going to be there, but this one, because if you're already looking at some point saying, well, maybe we need to adjust it, well, then we should change the language, because otherwise this is telling you start there and everything else suffers.
Okay, great point.
That's an excellent point. Shall and may are 2 different terms, so. We do. We all have stories. We could go around the room and do an icebreaker on this meeting of shall and may. The only thing I would just add is, in closing, unless someone else has something else, is as we move to now item 3 saying may, dedicate, or any of the other items that may have an impact to the community, I think we need to get in front of that in a community. Scott does an excellent job, and I think we need to think about how we spend the time sharing that it's not that we don't care about suicide prevention, or we don't care about the impact of mosquito abatement or whatever the particular item is, but I do think it's important because in talking to constituents, it's very clear whatever the body it is, there are legal requirements that you have to fulfill. And if you can't stretch that dollar, we have to do those. And so sometimes the others may not, especially on the 100% cost recovery. I think educating on why that is important. So that's all I would add, is having a community engagement piece that's attached to some of those impacts that happen with the budget. So any other comments? So
I got a question. It's a clarification on number 1.
Yeah.
So it's between 17% for an ending fund balance, correct?
Between 10 and 17.
Yeah, 10 and 17. So we're actually going to say just for this fiscal year, 17% is the top, or are we looking towards the future on that?
Well, I'm asking for it to come back as a policy, and I'm asking for it to read just as it is required, and that's at 10 to 17%. We're required by, the health is required by law, essentially by statute. So yeah, exactly. So I feel like that's what we need to fulfill.
Okay.
So this year we would fall under it because it's 10 to 17.
Sure. But it's already statutory there. We just go 17. I don't know why. Yeah, exactly.
Slicing and dicing here. I don't know.
Yeah.
Sure.
if it's a recommendation of our district health officer to staff to go to 17, we should do it.
Right, except it's at least 17. So now we're gonna get into semantics.
Yeah, gotcha.
So we'll see what happens on the agendized item. Hearing no other discussion on this, I'm gonna close item number 11. We're gonna move back to item number 10. For the record, I'm opening back item number 10. Do we have any further discussion on item 10? Any comments, any additional questions? We don't have any. This is an actionable item and would entertain a motion at this time.
I would move that we accept the proposed budget as presented by staff.
And I'll second. Oh, go ahead. Mr. Brown will second. Any further discussion? Hearing none, all those in favor signify by saying aye.
Aye.
Any opposed? Motion carries unanimously. Thank you so much. We'll move now to item number 12, which is public comment.
Under this item will be limited to 3 minutes per person, may pertain to matters both on and off the board. Time may not be allocated to other speakers. Comments are to be made to the board as a whole, virtual public comment. Be restricted. However, restrictions may be imposed on the time, place, and manner of speech. Irrelevant statements, unduly repetitious statements, and personal attacks that would objectively antagonize or incite others are examples of speech that may be reasonably limited. This board carries out the business of Northern Nevada Public and its citizens during its meetings. The presiding officer may order a person removed if the person's conduct or statements disrupt the order and safety of the meeting. Warnings about disruptive conduct or comments may or may not be given prior to removal. Furthermore, certain disruptions of a public meeting or criminal acts is defined under NRS, which may result in prosecution in appropriate cases. And we do not have any requests for public comment.
Thank you so much. Go ahead and close public comment and open up item 13. Any board comments? Dr. Danko? Dr. Danko, do you have any comments?
Yeah.
I think Mr. Anderson.
The only thing I want to say is thank you to all the staff, everyone that's been involved with all of the topics that we've covered today, including the budget, which is not a fun topic to be discussing right at this time, but just want to say thank you for all the time, energy, effort that you have gone.
I was going to say that, so we might actually meet I have 1 minute. I just wanted to say thank you so much to everyone. Putting all of this together is a lot of work, and we recognize and appreciate everything that you do and helping our community and help educate everyone, especially as we go down these paths that may not be as nice as we would like them. There are going to be challenges, and I think everyone recognizes that. I certainly want to thank you, Ms. Olson, for your facilitation and all your hard work as well. And I don't know if you have any closing comments. I certainly appreciate you.
Only thank you. Closing comments would be, we were looking for like 30,000 foot direction from where we should be focusing for the next 3 years-ish. Community needs, budget, focus there. That's super helpful. And we purposely are leaving it undone, so it feels undone because we just need the opportunity to take the feedback back and then process it through. But we heard all of your comments. We have documentation of the requested follow-up as well. So thank you. It's always very insightful. And then we'll get to work. And I'll pass it to Dr. Kingsley for wrap us up.
And just reiterating on those points, I want to say thank you for the board and for that 30,000 view and sometimes the 10,000 view and 1,000 view that you provide to us and help us provide that direction and get staff and the contributions that they make to our community. Asking impact that we have. Grateful and grateful for our federal partners, our state partners. Again, through many of these points before, but we are opposed to continue to grow and do great things.
Well, I'm going to close it out with someone who shared with me during the break that something that was shared to the person, and that was every time you say, and I'm going to close it by this way, every time you share something with someone, smile. Wasn't that beautiful? So I'm not going to say who that was, but honestly, so I say from our hearts, right, to all of yours, have a wonderful day. Thank you so much. This meeting is closed at 12:02.